So today we have a slide seminar. The topic is utility of immunohistochemical marker in the diagnosis of CNS tumor as per current WHO classification. The presenter of today's talk is Professor Epari Sridhar sir. He is from Department of Pathology, TMS Mumbai. The chairperson of today's talk is Dr. Abhishek. He is Associate Professor, Department of Radiation Oncology, TMH. These are the participants of the today's talk. I would like to request all the participants to please introduce one by one, starting with Dr. Shreya. Dr. Shreya.
Good evening, all. This is Dr. Shreya Giri, second year PG resident from JNMC Wardha.
I'm Dr. Anita Roni, second year resident from NIMS Hyderabad.
Good evening. I'm Dr. Abhirami from third year resident from Basavatarakam Indo-American Cancer Hospital, Hyderabad.
Good evening. I'm Dr. Hanan Ashravi, PG second year from GMC Jammu.
Good evening. Myself, Mohammad Nakib, second year PGT from Bardwan Medical College.
Dr. Kumudini.
Good evening, I'm Dr. Kumudini, second year resident from MLNMC Prayagraj.
Welcome all of you. So today moderators are myself, Mohammad Tala, and Dr. Pooja Gajaria. She is ex-fellow neuropathology and ex-SR of Mumbai. Some reminder, if you have connection interruption, low or no sound, video freezing or video lag, kindly leave the meeting and rejoin with the same link. If the problem persists, please check with your internet connection. Please answer the poll question by typing in the chat box. Please do not send requests for annotation to the presenter. The other disclaimers. Before starting, let me remind about the upcoming talks. The upcoming talk is on 25th July. That the topic is how a pathologist can suspect immunodeficiency by Dr. P. Saikia, PGI-MER, Chandigarh. And after that, we have on 27 July, we have a slide seminar on immunotherapy, principle and case-based application, including CAR cell by Rajiv Kaushal and Gaurav Narula. Without wasting any time, let's start this talk. Over to you, sir.
Thank you. Can I share my presentation?
Yes, sir.
Yeah. Is it visible?
Yes, sir.
Is it fine?
Yes, sir.
Hi, all of you. Welcome to this edition of online teaching program. So today, the next couple of hours, we're going to have some slide seminar of typical cases, which will help us to understand the utility of immunohistochemistry in the diagnosis of CNS tumor when you want to classify them in as per the current WHO classification. So before I go, I wanted to highlight this. This would be our plan today evening. The cases to be discussed will encompasses three broad groups of tumors. One is the adult diffuse gliomas, ependymal tumors, and the primitive amyloid tumors. What you'll encounter today will be a stereotypic cases. Only this thing to make you well versed with the major molecular group of each of these broad family of tumors. Not to think too much, just to make averse and well versed with this, so that you should be easy. I understand these CNS tumors are extremely uncommon. They're less than 1% of all human malignancies. So you need not be scared of this thing. In real practice, in reality, you might encounter very rarely or uncommon. So just enjoy this slide session, and to make you aware of this, whatever, in case if it is new features or new findings for you or new things for you, just learn and get acquainted with the terminology. And we'll be happy if you have any questions, you post it in the chat box, we'll try to address it. So before we go into the cases, I just wanted to highlight, I know this has all been covered in the previous talks in various talks of neuro-oncopathology. What you want to understand is currently we are following the 5th edition of CNS tumor classification. In fact, this is the 5th edition, but there are 6 different versions of books for the WHO. The 5th book was in fact an updated 4th edition, and now the 6th one is actually the true 5th edition. You can say that earlier the classification used to be based on histology only. They used to be called as histological classification. Now the current classification is histomolecular classification. This is the big thing you should understand. The WHO classification is based on integrating histology and molecular markers. So probably only by histology you will not be able to diagnose an entity. You need to incorporate the molecular findings. Today in our cases, how we can get the information of this molecular marker by immunohistochemistry, we will learn. So a few things about the current classification. This is in the lines of 2016, that before updated version of this, and it has incorporated all the recommendations by CIMPACT now. So there is, in this classification, there is a movement more towards incorporation about the molecular features into the CNS tumor classification. There are new chapters on the genetic tumor syndromes. There are entities like NOS and NEC categories have been retained. I hope you'll be knowing what are NOS and NEC. Probably in the case-based discussion, we can elaborate further on that. So these are the basic overall groups of the tumors in the current classification. What we are going to touch today is the first family group of gliomas and the embryonal tumor. The gliomas is a big family of tumors. Only a subset of the gliomas, like adult diffuse gliomas and ependymal tumors, will cover. So if you have to just recap about the classification of the CNS tumors in of this current 2021 classification, the gliomas, gliolural tumors, and neuronal tumors are all clubbed in one big family of tumors, in which one group is adult type of diffuse glioma. The second group is pediatric type of diffuse low-grade gliomas. The third group is pediatric type of diffuse high-grade gliomas, and the fourth is circumscribed astrocytic gliomas. And the final group, what you can say, is glioneuronal and neuronal group. These are the major 5 groups which include under this family of gliomas, glioneuronal tumors, and neuronal tumors, have different other smaller family groups of adult type diffuse, pediatric type of tumors. Now, today in our edition, we'll see about the adult type of diffuse gliomas. So for ependymomas, you have this classification of this is supratentorial ependymoma, posterior ependymoma, spinal ependymoma. Each of these groups are divided into supratentorial different molecular groups, which you will see. The supratentorial 2 major groups is ZFTA fusion positive, and second group is YAP fusion positive. For posterior fossa group, there is no name to it. It is group A, that is group B type, PFA and PFB. And spinal ependymoma is based on the histological vixopapillary subependymoma and the new entity, which is anemic amplified. So today we are going to cover the supratentorial and posterior fossa group. Embryonal tumor, as you know, all of them, like the most commonest is medulloblastoma. Non-embryonal medulloblastoma tumors are the other spectrum, ATRT, the stereotypical teratoid rhabdoid tumor. Repliform neuroepithelial tumor is crinoid. Embryonal tumor with multi-layered rosettes. There are uncommon tumors of CNS neuroblastoma, CNS tumor with BCOR internal tandem duplication, and CNS tumor, CNS embryonal tumor, NOS. Of these, atypical teratoid rhabdoid tumors and embryonal tumor with multi-layered rosettes, what you call as ETMR, are molecularly defined, at least in variant alteration defined. The rest of the tumors are based on certain amount of methylation and certain combination of alteration. These 2 tumors can be identified in immunohistochemistry, which we'll cover today. Few things on the tumor grading. There is a chain paradigm shift in the CNS tumor grading. The no more it is graded by the Roman, it is graded by Arabic numericals. That is just like other other tumors elsewhere. It is graded by English Arabic numericals as 1, 2, 3, 4, and the range of grades has been retained. The grading was considered as intratumoral grading. It is not a distinct entity anymore. Like astrocytoma is one group, and in the intra-astrocytic tumors, you have 2, 3, 4. So the clinico-pathological grading, there are some things like, when you'll see medulloblastoma, it is always grade 4. It is no more like in this further grading. That's called clinico-pathological grading. And some of the tumors, you have molecular features added to call histological molecular grading, which we'll see some cases here. So diffuse adult type gliomas, there are only 3 major groups you want to understand. One is astrocytoma IDH mutant, oligodendroglioma IDH mutant and 1p19 co-deleted. And the third group is, which is not fitting into these 3, that all the rest of the tumors are classified as glioblastoma. What is to be understood here is there are only 3 broad groups of adult type of diffuse gliomas. The gradings are inside the each tumor entity, like astrocytoma IDH mutant is one group. Within the tumor, you have grade 2, 3, and 4. Oligodendroglioma is one group. Within the tumor group, you have grade 2 and 3. The glioblastoma is only one tumor, that is with grade 4. So you need to understand here, glioblastoma term is no more used for IDH mutant tumors. It should be called as astrocytoma IDH mutant tumor, followed by suffixing with the grade. So just to remind you, there is no adult IDH wild type astrocytoma that is grade 2 or grade 3 tumor. So when you call adult type IDH wild type tumor, it is classified as glioblastoma. So this is the conceptual evolution from histology to histogenomics. So you need to incorporate the genomic knowledge into it. So what you understand with this is, most important is you need to know whether any diffuse glioma is IDH mutant or not. Okay. With that, we'll start with the cases. Do you have anybody has any questions here? Like, you know, did not understand any aspect of it? Review, we just can clarify in one line. Pooja, are there any questions?
No, sir, no questions.
Okay. Then maybe we'll go to the first case.
Yeah. So Dr. Anita can take up the first case.
Yes. So case 1, it's a 28-year-old female with intermittent headache and motor speech difficulties and seizures 2 years back, and no sensory motor deficits. MRI shows a lesion in the left frontal lobe extending into the insular cortex and temporal lobe, immediately abutting the lentiform nucleus. And
So,
measuring 70 to 5 inches.
Anita, like, what do you infer from this? We'll go back to the history. So what do you infer? If you sum it up, the young 28-year-old lady. So what does the age signify here? Relevance here? Anita, we are not hearing you.
Sir.
So let me go back to the slide first, why we are talking about the age. What do you see here? What are the broad spectrum group of the gliomas here? One is
Adult type.
Adult type diffuse glioma. The other one is Pediatric type. Yeah. So is there any different broad groups are? One is adult type diffuse, the rest are pediatric type and circumscribed glioma. So first thing, when you see the age, of course, the adult type and pediatric type is not based on the exact age of the presentation. It is a molecular basis of it. But usually when you're seeing a 28-year-old, you expect them to be of adult type of diffuse glioma. So our approach is, first, when you are seeing the history, it should cross in our mind that first let's deal with these type of tumors. Only if we can't classify based on this tumor, probably we go into the other spectrum. That is why it is important to know the history, what you are seeing now. So 28-year-old female, so probably we are dealing with some adult type of tumor. Okay. And what does intermittent headache and motor speech difficulties, seizures for 2 years, the history is almost like 2 years. What does it signify here?
Tumor.
So one seizure is, tumor, which is there for relatively some tumor or any kind of mass lesion which is involved in the gray matter. So when seizures are coming, it is involved, cerebral cortex involvement is there.
Yes.
And at least we have in history, at least the presentation wise, at least 2 years of history. When you say 2 years of history, will you consider this as an acute presentation or what kind of presentation?
It's not acute, it is.
It is not an acute presentation. Yes. So it is probably some kind of a longish history type of presentation, which has got, based on this, some problem with the cerebral cortex.
Yes.
Right?
Yes.
So what does the radiology signify?
Frontal lobe lesion.
So when you read first line is ill-defined, what does it mean?
It is not circumscribed.
Yeah. So if you go back to your classification, you have got one group of tumor as circumscribed glial tumors, right?
Yes.
If you go back, you remember? Yes. Should I go back? What is this? Circumscribed astrocytic glial. When something in CNS tumors, when something is called diffuse, diffuse means diffusely infiltrating. It is not well defined. It's ill defined. So from the radiology, whenever being a pathologist, whenever you're seeing the radiological findings, your first goal to know, is it a very well defined or well demarcated or well circumscribed, or is it like ill circumscribed, ill defined, or very diffuse disease? So with this ill defined, what do you think it is? What do you think it is? Anybody else in the team?
It must be a diffuse involvement, sir.
So yeah, when somebody says ill-defined, it tells you that it's a diffuse lesion. We don't know what it is, and involving so and so frontal and temporal. As expected, it is also involved the insular cortex, and deep. It is going a little bit inside also into the deformed cortex. Okay.
Yes.
So other features like hyperintense lesion. When something like T2 hyperintense means what it produces, it is produced by some kind of protein-rich fluid or mucoid matrix. It's something like, a more space, fluid space between the cellularity. Abhishek, you want to add anything here? History, or you want to tell us, pathologist, like what you look into the history and the radiology?
Sir, this is a young lady, a 2-year longish history. Left-sided and frontoinsular. So everything is looking like this is going to go towards IDH actually.
So basically, let's not go into the IDH now. So
Right.
basically what Abhishek is trying to tell you is a diffuse lesion in an adult, and you feel the way it is done. What is that hyperintense edema? Anything, Abhishek, can you see that about anything edema will suggest something?
So if we have multiple sequences, what we can appreciate, especially you will have infiltrative disease and you have reactive vasogenic edema. So across multiple sequences, you can make some attempt at distinguishing them. And it also helps at distinguishing some further characteristics like we will come to later. So all of this adds on information.
Okay. So what he said, like, to add more, like when something is heterogeneously, it shows an heterogeneous features, it also tells you that probably histologically or histological features is also heterogeneous. The lesion has gotten heterogeneous features. Okay. And hyperintensity can have due to the proteinaceous fluid. With this, we have a young lady involving cerebral frontoinsular SOL, diffuse lesion. Anybody from team 1, what is your thought process here?
Sir, you are not that clearly audible anymore.
Able to hear me?
It's still less. It was better earlier.
Should I stop staring and do again?
We can hear you now, sir.
Okay. So what you're saying is a heterogeneous lesion. You're able to hear me, Pooja?
Yes, sir, we can hear you. I think there is some background noise coming from one of the participants.
Okay. So with this kind of information, surgery has been done. You got the tissue. What you have to do is you need to measure the entire tissue bits. Yeah, I think some disturbance is coming from somebody. So this is the low power view. Probably, Anita, you can describe.
Yes, sir. So this is an infiltrating tumor with areas of showing microcystic spaces.
So can I correct you here? Like whenever you're saying an infiltrative tumor, you need to demonstrate the normal parenchyma interface if you cannot. If you can't show, you need not say that likely.
Okay.
Okay. Can you see any normal here? So this is an overview here. You just tell us how is the lesion looking like.
There are areas of microcystic spaces.
Yeah, so you can say there's an area which is, well, you can make out it is cellularity. It is whenever you're describing a brain tumor, you have to describe cellularity in respect to the normal parenchyma. So is this a cellularity of normal cellularity or more?
It is hypercellular.
Yeah, so you should say at least you can see a cellular lesion with variable areas. Some of the areas you can say that this is a microcystic areas, other is relatively compact fibrillary matrix.
Yes.
Yeah?
Yes.
So this microcystic change, what you can pick it up in radiology as T2 hyperindex. Okay?
Okay.
So anything else you want to say?
Maybe in the next.
Okay, in the next one. Okay, yeah.
So you can see the fibrillary background and typical astrocytic morphology. And
no, not that way. What is astrocytic morphology? First you talk about the cells, then you can talk about the fibrillary.
okay. There is cellular pleomorphism, sir. There is hypercellularity.
First tell me the shape of the cells. How are they?
They are eosinophilic with
Probably in this you can elaborate the cell morphology here.
They're more like
Describe this area. Anybody else in the team? Can anybody describe this slide?
So there's multiple round to oval astrocytes having abundant eosinophilic cytoplasm, showing nuclear atypia. There is pleomorphism and hyper.
Can you elaborate one feature? Okay. So when you say astrocytic, what does it mean?
So
is there any particular feature to be called as astrocytic?
So there's eosinophilic cytoplasm.
So that is only one form of it. So I can advise you something. When you're describing a tumor, first you describe the shape of the cell. You say in this field, what you can see a tumor, there is a mixture of cells of varying sizes and shapes. Okay. Some of them are having a kind of a dense eosinophilic cytoplasm, or you can say plump cytoplasm, and some cells are hardly any cytoplasm. And they are not similar to each other. No two tumor cells are looking similar to each other and of varying sizes and shape. These are the features of an astroglial morphology. So that's I'll put it as an astrocytic. Okay. So when you see a tumor cellularity, when they are not monomorphic and each cell is different from the other cell, that is the biggest feature of an astrocyte. Conventionally, when you describe an astrocytic tumor, astrocytic cell, it is an elongated cell. You have an irregular nucleus. Sometimes you can have a plump cytoplasm and eosinophilic cytoplasm. And the gemistostatic ward should be only reserved only for the cells which have got dense eosinophilic cytoplasm, like what you see here. So these are the cells which you have. What you saw it in the previous frame. These are the cells which are seen in various. These are some loose areas. You can see that loose areas, and there are some compact areas. When you come here, what else you want to describe in this? You can see this cell. What is this cell? What is this one? How to describe this? Like this one, this cell. Can see the cell inside this? How do you describe it, Anita? What is this cell and what is this cell here? Is this cell and this cell same?
So which one are you talking?
Yeah, are you able to see me the pointer? I marked to encircle two cells. Are you able to see that?
Yes, sir.
Still not these ones.
Yes, sir.
You could make out this one cell here and this cell here. Are the two similar?
No, sir.
So what do you feel? How do you describe this cell and how do you describe this cell?
So the cell in the left, it has a scant cytoplasm. It is comparatively, it is hyperchromatic with
Very large nuclei
larger.
than the rest of the cells and irregular outline, you very more of hyperchromasia, right?
Yes, sir.
Than this
Yes.
cell. If you can see the chromatin is little bit dense and all. So these cells are probably the native caught up neurons.
Okay.
Okay, sir.
These are the abnormal cells. Sometimes some cells can be, like you can see similar cells here. You see this? I'm marking out. Those cells are different. They're
Yes.
probably caught up neurons. So that itself tells you that it has replaced the native parenchyma and diffusely infiltrating.
Yes.
Okay?
Yes, sir.
And what else you will describe in this field? So you can say that because you can see this nucleus is pleomorphic, larger than other cells, varying in size. So definitely pleomorphism is there, right?
Yes, sir.
What else you want to describe in a diffuse glioma histologically? You saw the cellularity, it is cellular. You said nuclear pleomorphism. What else you want to see?
So vascular proliferation.
So right after the anaplasia, you'll go to the vascular proliferation.
So background.
Yeah. Background.
Background, you have already told fibrillary matrix.
Anaplasia.
What is the difference between pleomorphism and anaplasia? Anybody in the team?
Anaplasia
There are
is
various-
loss of differentiation. And
Very good.
And pleomorphism is the different same different type of nucleus or morphology same, but the nuclear size will be different.
Different.
Yeah. So basically, if you have so many of this thing, pleomorphism, anosarcariosis, chromasia, and anaplasia. Anaplasia is a broad terminology. When you talk
Sir, we are not able to hear you.
of new objects. I think lost connection. Now you can see me?
Yes, sir. Now we
Yeah.
can see.
Yeah. So I think I got some call. I just, okay. So in case of neuro-oncology, when you're talking about anaplasia is a word which is conglomeration. Like, it encompasses pleomorphism, anisokaryosis, nuclear irregularity, chromasia, all features together. You put a broader term as anaplasia. So what is the next step you want to see after anaplasia cellularity? You want to comment about mitosis. Did you see any mitosis in this field? You must have seen the slides earlier also, right?
Yes.
You can look for it.
It's not that evident.
So you can't see a mitosis here. Is it important for a mitosis to be seen? Why is the mitosis important?
So for the grading.
Yes. What is the grade different? Like, if you find mitosis, where do you go? If you don't find mitosis, where do you go?
Significant mitosis, grade 3. A few mitosis. It is grade 2.
Mitosis in grade
It is
3.
grade 3.
Mitosis.
So there is a little bit of gray area about the number of mitosis required for an astrocytic tumor for upgrading it. There are various thought process, but I can tell you simplistically in a slide, if you find 2 or more mitosis, like less than 2, probably doubtful. At least 2, if you find it, it is significant to upgrade it to 3. Okay. So that's for histological grading. So here, after you see that cellularity and all, you need to comment about mitosis. Okay. So what is this in this field it is showing?
We are not seeing mitosis.
You're not seeing mitosis, but what is there any additional features in this slide?
Vascular.
So there is increased number of vascular channels, right? So is this a feature for a microvascular proliferation?
No, sir.
Anybody, Anita?
No, sir.
Abhirami says no. Anita?
No.
Shreya?
No, sir.
Why? Can Anita say that why this is not microvascular proliferation? Is this a
It's the
microvascular
endothelial proliferation, sir.
So you have to see endothelial proliferation. Is that what does it mean? Endothelial proliferation, how do I interpret?
You'll have a morphology like a glomeruloid like that.
So if you don't have glomerulus, you should not call it, right? What is this a microvascular proliferation?
We are seeing only a single layer of endothelial cells, sir.
Yeah. So you should be careful about over. So this probably amounts to increased angiogenesis, but it is not microvascular proliferation. So when you want to call microvascular proliferation, what Abhirami told is only one component of it. You need to have increased number of layers of endothelial, at least more than 2 layers, okay, with compromising the luminal space. Space also should be, and also the cells should be plump, endothelial should be plump. The glomeruloid is only one spectrum of microvascular proliferation. And endothelial proliferation is also one component of it. You can have tunica medial proliferation, you can have adventitial proliferation. So all these features together encompass microvascular proliferation. So in this case, what is that when you want to summarize, Anita, what are your findings? How do you sum it up from the clinical history to your histological features?
Should I tell about from the case?
Yeah, for the case 1.
A 28-year-old female, shall I tell them?
Yeah, go ahead. 28-year-old female.
A 28-year-old female with intermittent headache and motor speech difficulties.
That's fine. So you got in a 28-year-old female, you saw the histological, sum it up. When you want to summarize, you sum it up.
Okay, with a defined left frontal lobe lesion. And on microscopy, we find a tumor with microcystic areas of microcystic spaces with a fibrillary background and hypercellularity with cellular pleomorphism. There is no microvascular proliferation.
So what should be your findings now here? Histological impression.
It's a glioma, astrocytoma, diffuse glioma.
Yeah, so at this point of time, it's a diffuse glioma, astrocytic morphology, and not enough features which you are calling it to grade 3. Because microvascular proliferation is not there. Probably mitotic is there or not. Enough features of grade 3. So what do you want to do? So you have a 28-year-old lady, a diffuse glioma of astrocytic morphology. How will you confirm or negate your findings? Is there anything else you want to do? Or if you want to classify based on the current classification, what do you want to do?
Go for an IHC.
What IHC you want to do? Do you like to do GFAP in this?
GFAP could be positive in this.
No. You want to do it or no?
It would be positive in this.
So you want to do it or no? I'm not asking what is the expected finding. This is the tumor. You have to advise your immunohistochemist. You are saying, will you advise immunohistochemist or you don't want to advise immunohistochemist?
We would advise immunohistochemist.
So what is the immunohistochemist you want to advise? Shreya?
IDH, sir.
Very good. So in an adult diffuse gliomas, we saw that this is a diffusely infiltrating tumor. First goal of ours is whether it's an IDH mutant or IDH wild. So you have one immunohistochemistry available, which is for the commonest IDH, you can say commonest mutation, that is for IDH1 R132H. It's a type of IDH1 mutation. You have an immunohistochemistry available for that. Will you like to do that?
Yes, sir.
So anything else?
So ATRX.
ATRX.
We'll come to that. So what should be the IDH panel and what is this? Like Anita, can you interpret this? This is an IDH1 R132H.
Yes, sir. It is
Interpret.
diffuse positive.
So where is it? Diffuse positive means?
Cytoplasmic.
So are you expected to have a cytoplasmic positivity?
Yes, cytoplasmic positivity.
So IDH1 R132H is an cytoplasmic marker and it comes diffuse because of the mere feature of astrocytic tumor of the processes going everywhere. It gives you a kind of a blush-like diffuse positivity.
Yes.
And the best way to see that it is not a non-specific, you can see the endothelial cells here, they're negative.
Yes, sir.
Yes.
You saw that? So this is a protein, mutant protein, which is not expected to be there in the normal tissues. Okay?
Okay.
You understood? So is this abnormal or normal now?
It is abnormal.
It's abnormal. So you have to be careful here that there are in the market, you get an antibody for plain IDH1. It's a normal protein IDH1. If you do IDH1, you will get positive in all cells. So if that is why it's very important to you to know this is an IDH1 R132H antibody, which is a mutant protein antibody. Okay. So this is the brown, which is the dye. You can see it's a diffusely positive. You can say that it has worked well because the negative cells expected are negative here, endothelial cells, right? So now that you got an IDH, so what you will call it? It's an IDH mutant or IDH wild type?
Mutant.
So mutant, what are the IDH mutant gliomas? Can you call this as a glioblastoma now?
So
No,
You
sir.
cannot call glioblastoma because it is IDH mutant. But glioblastoma, to call glioblastoma, it has to be IDH wild type. So of all the three groups, what you have in adult type, you had one astrocytoma, you had one oligodendroglioma, one is glioblastoma. Okay. So now you got IDH mutant. So glioblastoma is excluded.
Yes.
What are the other two remaining?
Yes, astrocytoma and oligo.
Astrocytoma and oligo. Okay. And morphologically you favor?
astrocytoma.
Astrocytoma. Do you want to confirm it?
Yes, sir.
Yes, sir.
If you have to confirm it, how you can confirm? Is there anything markers?
ATRX, sir.
Can you expand ATRX? What is ATRX?
It is alpha thalassemia mental retardation X-linked syndrome.
So has it got anything to do with the syndrome? You mean to say this lady is alpha thalassemia X-linked related something you're investigating? Abhirami?
It was first identified.
Very good. It is actually the gene alteration was first identified in that syndrome. The protein is named after the translated product of the gene. The gene was named and nothing to do with alpha thalassemia mental retardation disease. Okay. So this is, so how is ATRX is going to be informative for you?
So if it is ATRX is mutated, then there will be loss of protein expression.
Okay, so loss of ATRX expression, how does it help you?
Diffuse
So if the ATRX, if it is retained, if the expression is retained, we will think of oligodendroglioma. And if it is lost, then we will go towards the astrocytomas.
Okay, Abhirami, is that the same or you just want to modify a bit?
So in diffuse, okay.
Online.
Sir?
I'm so sorry. I'm just getting a call. Then the network is going off. Am I seeing you people are able to see the screen now?
Yes, sir. Yes, sir.
Yeah. So ATRX, you told Abhiram, you are trying to tell something. You want to correct it. What Shreya told?
So if you see any loss of nuclear expression, it means that it is of astrocytic lineage.
Okay.
In diffuse.
So more appropriate, Shreya. The Abhirami, what she said was right. So it's not the retained is more informative.
Yeah.
It's the loss which tells you that it's an astrocytic. Retained, you still can get it in astrocytic tumor. You still can get it. You get it in oligos.
Okay.
So when there is a loss, it's a mutually exclusive. If there is a loss, you cannot think of oligo.
Oligo. Yes.
Cannot think of oligo. Retained, you can still think of an astrocytic.
Okay.
But loss, you cannot think of oligo.
Okay.
Okay.
Yes.
So in an IDH mutant tumor, ATRX loss is always indicative of astrocytic. Okay. Whereas ATRX retained in IDH mutant is most of the time it probably reflects oligo, but it is not absolutely 100% true. There will be a small subset of 3 to 4% of cases you can still get astrocytic tumors with ATRX retained. What is important for you is whether it's a loss means you stay away from oligo. Your morphological expression is impression is an astrocytic tumor. When you are doing an IHC, you wanted ATRX. Okay, so ATRX is a protein, as somebody said rightly, that you are supposed it will help the loss of function alteration of the ATRX gene is characterized by astrocytic tumor. So any alteration which causes loss of translation or protein loss, you will see as marker of an astrocytic. So we did here ATRX. How will you interpret it, ATRX here, Anita?
Sir?
This is in higher purview, the same thing.
So there's
Loss of expression.
loss of expression.
I mean, how do you say? Can you
control positivity is seen in the vascular?
So what is this one? What is this one here?
Endothelial cells, sir.
So is it lost or retained?
That is retained. That is
so this serves you as an internal control.
Yes.
Every native cell should be ATRX retained. Then only you'll be able to interpret that IHC for ATRX. Okay, you can see the tumor cells are ATRX loss. So what does it tell you once ATRX loss is? What does it mean?
An astrocytic.
It is not an oligodendroglial tumor. It's definitely an astrocytic. Your impression of astro. At this point, what is your diagnosis? Will you be able to add any more? So you had two groups, astrocytic and oligo. With this, what do you want to call?
Astrocyte.
Astrocytoma, comma, IDH?
IDH mutant.
So you got to the WHO class, right? So in adult diffuse gliomas, you had three groups: astrocytoma IDH mutant, oligodendroglioma IDH mutant, and 1p19 co-deleted. And the third one is IDH wild type, that is glioblastoma. So using an immunohistochemistry for IDH, you could classify this molecular group or classify CNS classification as astrocytoma IDH mutant with using IDH and ATRX. Okay. Yes. Additionally, if you have anything, you can use P53. What is this marker? Anita, what is this marker?
P53, TP53. I mean,
what is the marker like? What does it stain? How does it stain? Is it a cytoplasmic, nuclear? What is it?
Sir?
What type of stain it is? Cytoplasmic or nuclear?
Nuclear.
Nuclear.
So, is this a normal protein or abnormal protein? IDH1 R132H. You saw the IHC. Is it a normal protein or abnormal protein?
That is an abnormal one.
Very good. Mutant protein. You saw ATRX. ATRX is a normal protein or abnormal protein?
ATRX is a normal protein that.
Very good. ATRX is a normal protein. You are testing with the normal. What is P53 here? Normal protein or abnormal protein?
It is mutation. It is normal.
You don't have to bluff. Think, Abhinami.
Normal.
Normal only because there is a mutation.
So this IHC, what you are doing is P53 is a normal protein.
Yes.
You are just seeing the normal protein expression. In normal cells, you will get a normal P53 staining. p53 protein is a normal. In normal cells, will you get staining?
No.
No.
So the shelf life of p53 protein is very low. So in any state, normal state, you will never see a normal cell p53 positivity. Even if you get, you will get a very weak staining, but you will never get a strong intensity staining. Okay. So this is a protein overexpression. And you can use this as a protein overexpression as a surrogate to detect underlying p53 mutation. What happens in a mutation? You will have an abnormal protein. Because it's an abnormal protein, it cannot get degraded. It stays for longer period and it will pick it up. And whereas there are some mutation in such that there will be gross change in structure, using your normal protein IHC, you will not be able to pick up that abnormal protein. So there are two ways of detecting mutation. One is strong intensity staining cells. The other is absolutely no cells can. Okay. So here you get a p53 positivity overexpression. So likely to be p53 mutant. We don't know, but this is a surrogate, probably a p53 mutation because the overexpression which is not seen. So will it help you any further? p53 mutation, is it supportive of anything? So between the astrocytic group tumors and oligodendroglial tumors, p53 mutation is commonly seen in astrocytic tumors. Yes. So when you get an overexpression, it adds on to your information what you got it in ATRX. It tells you, reconfirms your approach or saying that astrocytic tumors, you thought it is an astrocytic tumor, you demonstrated p53 also, it's more closer supporting that you know that this is an astrocytic tumor, IDH mutant. Okay. And this is what?
MIB1.
K67 or MIB1.
Yes.
You see the labeling. Here for this MIB1, you are not supposed to interpret only the strong intensity. You are supposed to interpret any labeled cell. Intensity does not matter for the MIB1. It is the labeling it matters. And you need to calculate the labeling index, express in per 100 cells in the highest areas, highest labeled areas in the diffuse gliomas. This should not be used as a grading parameter, but it should be supplement to your whatever grade you thought. Okay, here the MIB labeling index is definitely more than 5%. You did not see mitosis, but the nuclear pleomorphism is more than what you expected for a grade 2. Probably it tells you that it is something more than grade 2 tumor, which you may not able to pick it up. So probably you will raise a suspicion as astrocytoma, IDH mutant. Probably one cannot rule out a possibility of grade 3. Radiologically, when you say heterogeneous, they will take it as at least grade 3, if not 4. Okay. So finally, what's your diagnosis then?
So it is astrocytoma, IDH mutant, CNS WHO grade 3.
So what is the most important marker you use here, utility for the molecular marker?
So IDH and ATRX.
So these are the two markers you can use as a molecular markers for dividing these astrocytomas, oligodendroglioma, and glioblastoma in adult type of diffuse glioma. Okay. If you want to sum it up as adult diffuse gliomas, what is the immunohistochemistry marker which is most important? IDH and ATRX. You can have p53 also as an adjunct to it, but if you want to put as the most important is IDH and ATRX. Okay.
Yes.
Is there any questions, Pooja, chat box mein?
Yes, sir. Can reactive gliosis be IDH1 positive?
Anybody from the Anita?
Sir?
Somebody has asked a question, can reactive gliosis be IDH positive?
Reactive gliosis.
Yes, sir.
Yes, sir.
Who said yes? Abhirami or Shreya?
Yes, sir.
Shreya said. Abhirami and Anita, do you agree with the same? Or do you have any difference in opinion?
So I feel
Shreya, let's ask you, what did you say about IDH1 R132H? Is it normal protein or abnormal protein?
normal protein, sir.
IDH1 R132H.
Normal IDH1 R132H is an abnormal one. It is a mutation.
So mutant protein will you like to be expected to see any, is there any abnormal cells in reactive glycolysis?
No, sir.
So then in a normal cells, are they likely to produce an abnormal protein?
No.
A
No.
mutant protein?
No.
So whenever you get a mutant protein positive, it tells that it's an IDH mutant tumor.
Okay.
Because it's a mutation. Mutation caused the tumor. This is the tumor driver mutation.
Okay.
It will be present in all tumor cells. It cannot be present in some cells. It cannot be. In glioma, IDH mutation is a driver mutation for the tumorigenesis.
Okay.
Okay, both for astrocytic and oligo. You cannot have some cells positive, some cells negative. When you are saying in presence of positive cells, there are some negative cells, probably the negative cells are not abnormal cells, they might be reactive cells admission. So the answer to it, reactive glycolysis are never positive for IDH1 R132H if you are using a mutant protein IHC. But as I said, there are in the market, you have IDH1 normal protein IHC.
Okay.
If you do normal protein IHC, what will, so Shreya, if you have a normal protein IDH1 IHC, what will happen in reactive glycolysis?
So it will be negative.
Normal protein IDH1.
Positive, sir.
It's a normal protein. IDH1 R132H is a mutant specific protein. IDH1 is a normal protein. So if I'm talking about IDH1 normal protein, what will happen in reactive glycolysis?
More.
It will
It should be there. It should be there in all cells. In reactive glycolysis also it will be there. Okay. What will happen in tumor? In IDH mutant tumor, what will happen IDH1? Normal protein.
Sir.
More likely to be negative.
Negative.
So choosing an appropriate antibody, you have to choose IDH1 R132H. Okay. So if you don't specify the type of antibody what you're asking, then you may land into trouble. So if you are interpreting something as reactive glycolysis and your mutant specific antibody you're doing and it is positive, it cannot be called as tumor. Okay. That question has been answered. So reactive glycolysis will never be positive for IDH1 R132H. Pooja, is
Yes,
there
sir.
any other questions?
Yes, sir. If it is astrocytic tumor on HE with mild pleomorphism, just like this case, and no microvascular proliferation or necrosis, but IDH comes negative, no mutation, what should we sign it out as?
That may be at the end of the other two cases, we'll address that.
Yes.
Okay. Any other relevant questions?
Is there any cutoff percentage of cells that need to stain to call it P53 mutated?
So we don't report anything. My suggestion would be don't ever report anything in the IHC as P3 mutant. You should always, there are two ways of reporting it. You can express the tumor cells, what percentage of cells are showing intense, strong positivity. You have to say that. Okay, that is itself says. As per the literature, anything more than 10% of the tumor cells showing strong intensity positive can harbor P3 mutation. It may not be 100%, but it is so. So anything more than 10% cells strong intensity positive is significant for you. According to your own convenience, you can use focal or diffuse positivity. When you say diffuse positivity, it clearly tells it is like P3 mutant phenotype. When you say focal, we are not sure whether it's a phenotype is mutant or wild type. So you can use it. So after writing the immunohistochemical finding, you can suffice saying that this is P3 mutant phenotype finding. This is P3 wild type phenotype finding. We can only as a surrogate. The staining pattern is used as a surrogate for an underlying P3 mutation. Yeah.
Yes, sir.
Next one.
So there are
go to the next
questions,
question.
but I think it
We'll
will be
go to the next
covered in
case.
the
Yeah.
subsequent.
Yeah. We can take them. So few things. What I wanted to tell you about the adult diffuse gliomas, there are, as you said, like few aspects that you'll read it. There are some tight correlations are there. IDH mutant tumors are either P3 mutant or 1p19 co-deletion. If you get a strong P3 immunohistochemistry, you need not do for 1p19 co-deletion because they are mutually exclusive. Similarly, 1p19 co-deletion is mutually exclusive for ATRX loss. If you have an ATRX loss and you are having a doubtful morphology, you are not able to distinguish between ATRX, astrocytic or oligo. ATRX loss tells you that it's an astrocytic tumor. You don't have to do 1p19 co-deletion. So you need to understand these three. So broadly, diffuse gliomas are three different groups. One group is IDH mutant, the other is IDH wild type. If it is IDH mutant, you need to distinguish whether it's an 1p19 co-deleted or ATRX mutant or P3 mutant astrocytic. Based on this first case, you can see that's a classic example. We can say that an astrocytic. Only in other cases, when you require, you can do 1p19 co-deletion. This is a flowchart or something we can use when you have an ambiguous morphology like an astrocytic or astrocytic oligoindol. First do an IDH immunohistochemistry. If you get a mutant, you don't have to do for sequencing for other things. If you don't get a positivity and if there is suspicion, you can use for sequencing to see the other uncommon mutations. If it is IDH mutant, check for ATRX protein, whether retained or lost. If it is lost, you don't have to do for 1p19 co-deletion. If it is retained, you need to do 1p19 co-deletion to identify oligo. Somebody was asking for IDH wild type. Suppose if it is IDH wild type, you can see if its histological features are typically growth for, you can call it as a glioblastoma. If it is a lower grade histology, you do for other molecular markers for EGFR amplification, third promoter mutation, other chromosomal abnormalities for classifying something as glioblastoma. So what is the current nomenclature? Diffuse gliomas, it can have intratumoral grading. If it is an astrocytic, you have 2, 3, 4. You don't call grade 1, 2, 3, 4. It only starts with 2, 3. Once it is diffuse in adult type, it starts with grade 2. And there is no more you can use the word term anaplastic in this classification. That is deleted. And glioblastoma word is only been reserved, or the terminal is only reserved for only the IDH wild type. So this is the current grading classification. In addition to the histological features, there is new feature which is added in this current classification is presence of CDKN2A, 2B deletion or homozygous deletion. Irrespective of histological features, if you have CDKN2A, 2B homozygous deletion, it is grade 4. Okay. Whereas when there is no IDH mutation, there are other molecular markers like EGFR amplification, third promoter mutation can be used as a molecular surrogates for glioblastoma, along with other features like combined gain of whole chromosome 7 and loss of chromosome 10. So for CDKN2A homozygous deletion, we can use P16 as a marker, as a surrogate for that. If you don't get any cell positivity, it can tell you probably it suggests that's a CDKN2A homozygous deletion. But when if you get a pattern like this, it tells that most likely it is not deleted. So you can use P63, but however, it is not internationally or consensually accepted as a robust surrogate for CDKN2A homozygous deletion. But you need to know for all the post-graduation, P63 is a weak surrogate immunohistochemistry marker for CDKN2A deletion. So case number 2, somebody can take it. Now case 2 and 3, we can go fast. Yeah, 2, please.
Sir, 19-year-old female with complaints of headache, vomiting, on and off vomiting since 1 month. There is progressive diminution of vision since 1 week with no history of seizures.
So what does it tells you?
Sir,
as compared to the previous one, again, same adult, young adult, shorter history.
With acute history.
And raised intracranial junction, that's what it tells you about headache and vomiting. Yes. Okay, progressive diminution is also a feature of it. So something is fast growing probably. Okay. Yes. So this is the radiological findings. We'll skip the Abhishek because he will give a summary at the end of it, two cases. So right again, frontoinsular lesion. Similarly, which has got some features suggestive of necrosis as well. This is the morphology. Can you describe it?
Sir,
you able to see this? Yeah, yes. Good.
Sir, the given picture shows increased cellularity.
Yeah, and also increased vascularity. You can see all blood vessels. And at this power, you may not be able to describe the individual cells. At least you can say that this is a lesion which is cellular more than expected than the normal parenchyma, right?
Yes, sir.
Yeah, so likely to be tumor. So this, how will you rate the cellularity here?
Sir, there is increased cellularity.
When compared to here, you can see the cellularity is increased. So there is a heterogeneity in the degree of cellularity.
Yes, sir.
Right? So what does it tell you now here?
Sir, there is geographical, previously there was geographical distribution of tumor cells. In this picture, there is enlarged pleomorphic astrocytes.
We don't know, right? Astro or not, because they're perfectly round glial cells. Okay, likely to be an astro.
Likely to be an astrocyte with a scanned site with scan to absent cytoplasm, sir, with fine granular chromatin. And also in this picture, I can see mitotic figures.
Yeah. Yes.
And
Is this the one we are talking about?
yes, sir. This is
okay. So at this point, what is your call? These are other pictures. What is the great difference between the first case and here? You can see the cells are not too much irregular.
Yes, sir.
They're rounded. If you can say they're more monomorphic than
Monomorphic population.
difference. The variation in size is there, but
Yes.
not shape-wise too much of variation.
Yes,
So
sir.
whenever you get like this, probably it's very difficult to say directly as an astrocyte. It can still be an oligolyte. Oligolyte, the biggest feature for oligodendroglial is monomorphicity. Okay, you may get hallowness or you may not get halo at all. But you are not seeing halo here.
Yes, sir.
Difference is it's a more or less monomorphic, mitotic active cellular tumor.
Cellular tumor.
And, sorry, what is the IHC you'll require?
So,
19-year-old diffuse glioma.
So IDH R132H.
So this is IDH R132H. How do you interpret this? What is your interpretation? Positive or negative, or you can't interpret?
So it is
when you see this picture, what is this?
So it is
this is first case.
Yes, sir.
This is positive.
It is
right?
negative, sir. Yes, sir.
So the current case is how it is looking.
So it is not showing the staining. It is negative, sir.
Negative. Very good. So what next then? So you have saying IDH is negative. So probably still not saying that you don't know whether you're dealing with a GBM or it is an IDH mutant. You really don't know. But at this point, you could not prove that it's an IDH mutation.
Yes, sir.
Right?
Yes, sir.
You're still having the same higher grade glial tumor. You could not classify whether it's an astrocytic or an oligo. Typically, IDH also you could not confirm. Still, you have high grade glial adult type probably because of 19-year-old. So what is this? It's an ATRS. How will you interpret this? What is the interpretation of ATRX here? What are you seeing here?
So there is so
you can see the endothelial cells are all positive here.
Yes, sir.
Yeah?
Yes.
And the tumor cells are not labeled.
There is loss of expression, sir.
Loss of expression. When there is loss of expression, what does it tells you?
So towards the, it tells me that it is not oligodendroglioma.
Yes, it is not an oligo means an adult difference. It has to be astro.
Astro.
Yes, now you're saying it's an astrocytic tumor, but IDH you have not confirmed it. It's a 19-year-old. So what next you'll do? This is P53. How will you interpret P53?
So it is diffusely positive.
So P53 mutant type of pattern. You got an mutant type of pattern, diffuse glioma, P53 mutant, and ATRX is also mutated or lost, astrocytic tumors. What next? Will you be able to call this is glioblastoma?
No, sir.
What is, then what you will know? What is this one? How will you evaluate this one?
Studies for ADH1.
Yeah, very good. So whenever you have an ATRX loss and you have PIP3 mutant phenotype in a younger adult, before you jump and say that it is not an IDH mutant, you need to advise gene sequencing studies to prove that it is an IDH mutant. So here you cannot write IDH wild type just because your IHC is negative. There are so many different varieties of mutations are there. IDH immunohistochemistry IDH1 R132H is only picks up the commonest type of mutation which is seen in 85% of cases. So if you don't get it, it's not in IHC. If it is not positive, that doesn't mean it is wild type. So what are the markers which might suggest that it is an IDH mutant when you have an ATRX loss? ATRX loss in cases of astrocytic morphology, you should always advise for gene sequencing for IDH mutation. Okay. And this is an OLIG2. We do it on OLIG2 because OLIG2 is also a marker of a glial differentiation. It is positive in both astro and oligo. Why we need to do in ATRX loss cases in younger patient? Because there is an entity called diffuse hemispheric glioma histone G34 mutant where they can have ATRX loss, but it will be OLIG2 negative. Okay, so you do here, OLIP2 is positive, it tells you that it is not a histone mutant type. It is probably in this kind of scenario, you should advise for gene sequencing. Okay, that's what it is. So this is an adult, young adult, higher grade tumor, showed a phenotype like an astrocytic, but you could not prove an IDH mutant. You should always advise molecular evaluation for other molecular. Huh?
Yes.
Okay. So if you have to give a diagnosis at this point of time, immunohistomorphological diagnosis should be high-grade astrocytoma. Why you said astrocytoma? Because ATRX is lost. You can't give grading because you had no necrosis, you had no microvascular proliferation. You did not do any P16 or CDKN2 deletion, you have not done it.
Not done it.
So we have not. So that's the reason I'm not grading it. If at all you need to grade at least grade 3 if it is IDH mutant. If you saw that it is IDH wild type, then it cannot be grade 3. It is all becomes grade 4. Right? So that is why we need not grade here. You leave it as an high grade astrocytoma NOS.
Nice.
Okay. Only the grading comes into the picture after doing the IDH mutation studies. Okay. In this case, what is the expectation? IDH will be sequencing positive or negative? Usually it comes positive when they are assessed. Usually IDH wild type astrocytic tumors are glioma. ATRX are not lost in these cases. They are usually retained in IDH wild type gliomas. Okay. So here you can see then heterozygous point mutation. You can see that normally in the place of C, like two peaks are there. The C is the normal curve and you have a T red curve is this. It's a typical heterozygous point mutation, which is a variant type of mutation. Okay. Instead of CGT, it became TGT is the codon. It's a variant type 132C. IDH mutant. Here again, your diagnosis will. So what is your interpretation now? You proved, you done for molecular method, sequencing, you proved it is positive. Then what is it interpretation? Will you call glioblastoma?
No, sir.
No. So, and will you call oligodendroglioma?
No, sir.
So it is again remaining as IDH mutant astrocytoma.
Astrocytoma.
At least grade 3.
Grade
You have not done CDKN2 deletion to call it is. So what is, you saw two different cases. One case, you picked up typically IDH mutant by IHC. Second case, you had a phenotype of ATRX loss and TP3 mutant. In those kind of cases, you should always advise sequencing before you call it an IDH wild. Okay? The third case first, anybody, Abhirami?
It's a 60-year-old female with weakness and heaviness in the left lower limb and upper limb for past 8 days. No history of headache, vomiting, alteration of sensorium or diminution of vision. MRI showing?
Yeah, at this point yes. MRI, you got some lesion. An older lady, short presentation. Okay?
Yes.
That's what, short presentation. This is histology. What you will say?
So it's a diffusely, HNE showing a diffusely infiltrative lesion, cellular lesion.
Why you said infiltrating? Probably somebody says this is all normal, it's all tumor. So at this power, you can see some that I can make out. You see this? Some larger cells you are seeing here?
Yes, sir.
These are all native neurons, which are entrapped. So that means that area is completely effaced by these cells. So you can safely call it a diffusely infiltrating.
Yes.
You can make it cellularity is what you will, how will you grade the cellularity?
I feel it's moderately cellular, sir.
Very good. So you can't say very cellular. It is just marginally or more, little bit more than the native parenchymal cell. Right? Yeah. Next picture, how will you say that? What is the morphology saying that?
The cells are showing moderate pleomorphism.
First shape of the cell.
The cells are round, sir.
Irregular oval and round, a mixture of cells and pleomorphic.
Yes, sir.
Okay.
Pleomorphic, with showing increased mitosis also.
Yeah, some mitosis you can see here.
Yes. Yes, sir.
Yeah. You can see here, the high power, you can pick it up. But the cellularity is not packed.
Yes.
So what else you want to see now?
So is there any other microvascular
proliferation?
Is it there in your slides?
No, sir.
No,
Not
sir.
there. And necrosis is there?
No, sir.
Okay, not there. So at this point, if you want to summarize, how will you summarize the case?
It is a adult type, diffusely.
So older lady presented with a short history, a diffuse glioma, Histologically, what grade? At least grade 3 you can think.
Grade
Right?
3 or 4.
No, 4, how you know?
No, sir. It is grade 3, sir.
At least histologically grade 3, right? You don't have
Yes,
this thing. What is the markers you want to do?
So I would like to go with IDH.
First, you wanted to go for the IDH.
Yes.
Yeah, interpret it. IDH on the left side. This is the IDH.
Negative staining in the tumor cells, sir.
Negative staining in the tumor cells. Is it showing any other cells which is showing positive?
Here, I'm not able to make out in this field, sir.
So you are expected to see any positive cells in IDH? 1R132H?
No, sir.
No. So then it is negative. This is a negative.
Yes.
So it's not like something there is an internal control. This is an abnormal protein. There is no internal control for IDH1R132H. You should always use the external control.
Okay.
When there is no stain, it is you have to interpret as negative.
Negative.
Right?
Yes, sir.
So this picture is
Yes, sir.
ATRX. How will you interpret
There is
ATRX? Huh?
Retained. Positive, sir.
Retained. You can see this is an endothelial cell here.
Yes.
Huh?
Hmm.
You can see all are retained and the tumor cell cell is there.
Yes, sir.
So this pattern is different from the second case what you saw. Second case you saw IDH negative and ATRX loss.
Yes.
Here ATRX is retained.
Retained.
So
Having an oligodendral origin.
why? What is oligodendral molecular markers? It also has to be IDH mutant. Oligodendroglioma has to be IDH mutant and 1p19 co-deletion. First and foremost, only when you have IDH mutant findings, then only you can think differential of oligo also. Here, you're still not sure.
Wild type.
You did not decipher any further. You had 3 groups, right?
Yes.
In adult diffuse glioma, IDH mutant astrocytoma, IDH mutant oligo, and glioblastoma, which is IDH wild. You have not got IDH positive, so you could not decipher whether it's a mutant type or you don't know whether it's a wild type, you don't. But what you saw, ATRX is not lost, it is retained. That means it is not a phenotype of IDH mutant astrocytoma. You saw first 2 cases of IDH mutant astrocytoma. Both the cases you had ATRX loss. Okay?
Yes.
At least with this pattern coming in, what does it excludes you that it is not the first subset. Astrocytoma IDH mutant, it cannot be. Okay? It can still be an oligo, it can still be a glioblastoma or IDH wild type tumor.
Yes, sir.
Is it right?
Yes, sir.
Yes, sir.
Any doubts on this?
No, sir.
No, sir.
So now at this point, what you want to do? So what is the P53 showing?
Retained.
Negative.
Positive.
No, it is negative.
So you don't have to say negative. Some cells are there, but less than 10% of the cells are strong positive. So it is not a typical P53 mutant pattern of protein, right? So still, this finding also cannot tell you further whether it's an oligo or not an oligo or a IDH wild type glioblastoma. Maybe as expected, it is higher. So at this point of time, what exactly your differentials are?
It must be glioblastoma.
Wild type glioblastoma.
So you had 2 differentials here because of the 3 groups. One you could exclude it. It is definitely not IDH mutant astrocytic loss astrocytoma because ATRX is not lost. That is out. Between these 2, you cannot distinguish between oligo and this based on IHC finding. But morphologically, you felt it is more of an astro.
Astro.
Right? That's the feature which goes negative for oligo.
Yes, sir.
So what is it? So probably if you have to investigate further for a glioblastoma, what are the molecular markers you have read in? You
So
should
I
do
can-
EGFR, third mutation, or combined gains of chromosome 7 and loss of 10. Okay. So at this point, either you want to do IDH mutation studies. If you do IDH mutation studies, if it is negative, you can safely say it is a glioblastoma like, or upfront and positive marker reinforcement like what you can say. Here, your impression is a diffuse astrocytoma NOS because morphology is an astrocytic tumor. You could not prove it that IDH mutation is there or not. So NOS means you're not evaluated molecularly further. So advice is, I will advise either IDH mutational studies or an EGFR amplification or TET promoter mutation studies. Which one? So we did here by EGFR
So
by
one minute,
fish.
sir.
Yeah.
So since the age of the patient is more than 60 years, it's like more than 55 years, do we have to go in for genetic studies, sir?
So that's a thing. See, these are all 55 years and all are surrogates.
Okay.
Okay. And here your histology is not like typical grade 4.
Okay, sir.
What I'm trying to emphasize here, it's like intermediate grade type of histology, grade 3 tumor. If you would have got a classic case of grade 4 and microvascular proliferation necrosis, probably an ATRX retained, there is no need to go further. You might use as grade 4 tumor as this. But here you have not got histologically grade 4 features.
Yes,
You
sir.
got grade 3 type of features. Can we call it as grade 4? No.
No, sir.
First, you need to call grade 4 means you need to prove that it is not an IDH mutant type. Or you need to prove any molecular markers of glioblastoma like third promoter mutation and EGFR or this way. So you to advise. Easier thing is to do the EGFR amplification. What you got an EGFR amplification. This the red is implies for the EGFR. What does it mean now?
It is amplified, sir.
Amplified means what's your final diagnosis?
Sorry, sir. Glioblastoma.
Glioblastoma.
EGF.
So
Grade 4.
EGFR amplified, you should never make a diagnosis of oligodendroglioma.
Yes, sir.
Okay? IDH mutation and EGFR amplification are mutually exclusive. When you get an EGFR amplification, this is one of the feature of grading. I showed you in the grading feature of glioblastoma. See this. The glioblastoma diffuse astrocytoma with no IDH mutation, either histologically grade 4 features or EGFR amplification.
Yes.
Okay, once you demonstrate EGFR amplification here, it automatically tells you it is glioblastoma.
Yes.
Right? Huh?
Yes.
So you used your morphology and IHC here to say that it is not an IDH mutant astrocyte because ATRX is not there. And it's not having an oligo-like morphology, likely to be IDH wild type. Because it's a lower grade histology, you did some additional marker, EGFR amplified. So your diagnosis is glioblastoma, we can bracket. You can put it as EGFR amplified, CNS grade 4. This is one of the example where histologically you have not got features of grade 4, but molecularly you showed the features of grade 4. This is what I meant to say, that histogenomic classification, right? Okay. So this is, we'll skip this slide for that, whatever there in 2016, now it is like in 2021. And this I can circulate this slides for you for the interest of time. I'll skip that slide just to have a say. For an approach to your all the tumors, unlike the grade first, you need to ask any diffuse glioma, is it IDH mutant or not? First question you need to ask. Okay, rather than astro or oligomorphology, grade, you first ask IDH mutant or not. Okay, if mutant, then you have any surrogate information for CDKN2 deletion or not. Okay, but that's your first thing. If it is only IDH wild type, then think of glioblastoma. No glioblastoma term is used for grade 4 IDH mutant tumors. Okay?
Yes, sir.
The schematic picture, what we discussed here, we are talking about here, in an adult diffuse glioma, there are two big groups, IDH mutant group and IDH wild type groups. In IDH mutant group, there are two broad groups of an astrocytoma and oligo group. If you have an ATRX loss in astrocyte, it cannot be oligo. ATR is retained cases, you can use 1p19q co-deletion, call for the oligo, and subsequently grade 2 or grade 3 based on the features. If in case of IDH mutant tumors, lower grade of histology, you should demonstrate CDKN2 deletion. If there is no deletion, you can grade 2 or 3. Without having a information of CDKN2 deletion, you cannot call something as grade 2 or grade 3. Wherever you don't have information, you cannot say the grade cannot be assigned due to lack of information about CDKN2A gene status. Okay. So at this point, maybe Abhishek, you want to sum it up anything about the diffuse gliomas? Abhishek, are you here? Pooja, are there any questions which you want to take it?
Yes, sir. Most of those questions are answered. One question is there: if IDH1 R132 is negative, also negative by molecular studies, and ATRX is lost, then what do we call it?
Sorry, can you ask the question to the presenters?
Yeah.
Abhishek is not able to unmute herself. Maybe you can ask Ruchi to unmute him.
Yes, sir, I'll tell her.
Yeah. Did you listen to the question? Shreya, Anita, and Abhirami?
Please
Yes, sir.
repeat.
Can you repeat the question, Pooja? They did not hear it.
If IDH1 R132 is negative, also negative by molecular studies, and ATRX is also lost, then what do we call it?
IDH is negative.
Anita?
Is pause. ATRX.
Yes, she's saying that IDH is by negative by sequencing as well. Has that been done for IDH2 mutation also, or only IDH1?
Then
So if both sequencing IDH1 and 2 are negative,
glioblast.
you don't go into the ATRX. It becomes IDH wild type of tumors. You're looking into glioblastoma unless you rule out other markers like histone mutant tumor, G34 mutant tumors. I told you they can also demonstrate ATRX loss.
Okay.
So if IDH wild type is there, if you exclude other alteration like histone, then you can call glioblastoma. There is nothing more signifying on ATRX. Is that clear, Abhirami, Anita, and Shreya?
Yes,
The
sir.
first is IDH mutant or not. If IDH mutant, then only the ATRX interpretation come into your picture. Okay?
Yes, sir.
If IDH wild type, can it be a oligodendroglioma?
No, sir.
IDH wild type, no.
No, sir.
It cannot be. If you see the three broad groups of adult diffuse gliomas, IDH wild type is only glioblastoma. Okay?
Yes, sir.
Yes.
Yeah. So there is nothing great in that. So Pooja, am I clear for that answer?
Yes, sir. Yes, sir.
Yeah. So Abhishek, you could unmute Abhishek.
I don't think I have informed Ruchi.
Okay, then we'll go on to the fourth case then.
Okay, sir.
Okay?
Yeah.
Yeah. I think Abhishek is messaging me that he's not able to unmute. No problem. I think Abhishek probably after the second set of cases, you can come up and you can summarize both together. Until that time, Ruchi might figure it out how to unmute you. So case 4, maybe the team, second team, whoever is there want to. No. I think the first team only 4 and 4, 5. Yeah, 4. Take it up. Shreya, who is taking up case 4?
Yes, sir.
Take it up.
24-year male.
So this is a series of the same family of tumors, so we can go fast.
Yes, a 24-year male with complaints of headache since 4 months. There is no sensory motor deficit. There is a left thalamocapsular lesion causing obstructive hydrocephalus, sir.
So young adult,
Young
little
adult.
bit relatively shorter history and deep-seated.
Yes.
Deep-seated lesion. It's not typically hemispheric, deep-seated.
Yes.
So what does it show?
So cellular tumor.
You can see here some microcystic areas.
Microcystic areas.
Compact areas here.
Yes.
But what is conspicuously seeing that there are so many blood vessels.
Yes.
Okay. And between there are cellular area. There is no normal structure here. So you feel all that this represents a tumor, cellular tumor with very frequent vascularity. There are areas of low cellularity as well. You can see that.
Yes.
Huh?
Yes, sir. So the given picture shows a microcystic background.
Yeah, here.
There is vascular proliferation as well.
Proliferating blood vessels rather than vascular proliferation because there is no layering or anything. It's just a
blood vessels.
proliferating blood vessels. Then what is this area showing in the same tumor? What is this area showing?
So
that area you saw low cellularity.
This
cellularity is compact cellular crowding type. There is no hardly any space between the tumor cells.
Yes, there are nests of cells which are arranged compactly.
And showing variation in size also.
Yes.
What you can see, this is vessels.
Vessels.
Right?
Yes, sir. Proliferating blood vessels.
These are the microcystic spaces in the higher power. So they are not really microvascular proliferation, but they're subtle that they're doubtful. At this point, what is your panel you want to do it?
Sir, I will go for IDH
So
R132.
now you understood very clearly that whenever you see an adult diffuse glioma, irrespective of astrocytic or oligo-like morphology, you first start with IDH,
IDH.
right?
Yes, sir.
So we did oligo too, that's fine. IDH. How will you interpret IDH?
Sir, it is negative, sir.
It's negative. So this is an olic 2, which is showing some positivity.
Yes, sir.
Okay.
It is
So it tells you that it's a glial only.
Yes, sir.
So this is ATRX. How will you interpret ATRX?
Sir, it is retained, sir.
Loss of expression.
Why you said retained?
Sir, some cells are showing positivity.
Yeah, these cells are showing positivity.
Control.
There will be always native cells will be there, no?
Yes.
It's infiltrating tumor. So this is a perfect case. You can see the predominant predominant cells are negative.
Negative.
You can see this.
Yes, sir.
And in between these are cells, you can see this is a vessel here. This is a vessel here I drew it. These are normal cells. This is a vessel here. So these are normal cells. This is a vessel here. Vessel here. So endothelial cells are positive and this is all vessel. This is also vessel. So some scattered single cells are there, which is not a, but the predominant cells are negative. So this is a perfect case which is showing loss of expression for ATR.
Yes.
Okay.
Yes, sir.
This is P53. How will you interpret P53 here?
Sir, it is positive, sir.
Positive, it's a mutant type of phenotype, right?
Yes.
So what next now? So what is the difference between this case and the previous cases? So here is the phenotype is more or less the first two cases also showed ATRX loss. It is more closer to the second case what you saw that ATRX loss, IDH is negative, P3 is also positive, but the location is different. It's a deep-seated thalamic and that was a more cortical lesion. Okay?
Yes, sir.
Okay. So here what you need to bring into the picture, if you remember the classification earlier of CNS tumor, a pediatric type of high-grade tumors which can cause as diffuse midline glioma, which is histone altered. So pediatric type is there. Those kind of tumors can also be seen in younger adults. Because it's a thalamic location, first you need to prove that this is, at least your immunohistochemistry, prove that it's not an histone mutant. What are the markers which you can use for this? This is H3K27ME3 is a marker which is a trimethylated protein. In cases of mutated tumors, there will be loss of trimethylated protein. Okay. So here it is again a normal protein. You are supposed to interpret whether it is present in tumor or not. How is this a pattern similar like ATRX or not? Or P53? You had two different pictures. One is ATRX, you saw P53 also.
Just like
Pattern of
ATRX.
staining?
ATRX.
It's less. So that means there is a loss of H3K3, right?
Yes.
Whenever you have a deep-seated midline location, thalamic, cerebellar, spinal location, peduncular location, when you have it, when you have an H3K3 loss, you should suspect diffuse midline glioma. What are the markers you have for diffuse midline glioma? You have H3K27M. I've written it is histone M. This is H3K27M. It's a positive, just like IDH1R132H is then IHC for a mutant protein. H3K27M is a marker for mutant histone protein. This positivity tells like it is histone mutant. Unlike that, this is. So what does it makes it now? This an EGEP is a protein which is negative. We can use for both. So what is the diagnosis now?
Sir, diffuse midline glioma.
H3K27.
H3K27.
As per the current terminology, H3K27
Altered.
altered. Okay, you can put it in the bracket as H3K27M mutant. Okay, because you demonstrated mutation by IHC. Here, unlike the rest, first case you saw IDH1R132H mutant specific antibody IHC for IDH mutation. Here you saw H3K27M mutant specific IHC for H3K27M mutant midline. Okay. So this is also an IHC utility. You can pick it up. So best way to use is you should use a combination of H3K27ME3, which should be loss in mutant tumors, and positive marker in an S3K27M. So one S3K27M will be positive, that is mutant, with the loss of S3K-ME3 loss. Both will help you to say that it is showing 100% concordance with molecular sequencing. You don't have to subject any molecular additional marker to diagnose it. Okay? This is diffuse midline glioma S3K27 altered CNS. You can put it CNS WHO grade 4, even though you have not found histological features in as grade 4. You did not find microvascular proliferation, you did not find necrosis, but still you found histone mutation. That's why it upgrades the tumor as grade 4. This is again histogenomic classification. So the utility of immunohistochemistry of ME3, S3K27 ME3 and S3K27M. Okay?
Yes, sir.
So this is the literature around it. We'll skip for it. What you need to understand is when you demonstrate a midline location and you demonstrate S3K-ME3 loss, it tells you that it is a diffuse midline glioma. Absolutely, there is no mandatory that you need to subject for the clinic for evaluation for histone mutation for treatment purposes. Of course, if you want to do it for the clinical trial setting, you might have to do it. Okay? Case 5. Anybody?
It's a 37-year-old male. Complaints of headache and vomiting on and off since 1 year. MRI showing a large altered lesion in the right temporoparietal region.
Okay. So on and off since 1 year.
Yes.
And this thing.
Yeah.
Okay. So it's very difficult to say. You can't say acute presentation. You have something. So what is the histology says?
So H&E
How will you
section
describe
showing.
this?
Yes, sir. Tumor cells which are round to oval.
It's a
Having
very cellular tumor.
cellular lesion. Yes.
Absolutely no normal cells you are seeing. You can see that they're quite discohesive. You can see that discohesive. Now we describe the cells.
Yes, sir. They are round to oval with eccentrically pushed pleomorphic nuclei.
Yes.
Showing irregularly chromatin with abundant eosinophilic cytoplasm.
Can you call this a gematocytic cells?
They are
More of
like, but more of epithelial.
Rhabdoid. Gematocytic will never have discohesive.
Discohesive.
And matrix is you can see the clear spaces. There is no matrix you're showing. They're discohesive. Gematocytic will have processes. Cannot be never so rounded off cells. You'll have something like so. This you should not use the gematocytic for this. This is typically what you call rhabdoid-like or an epithelial-like. Okay, but what is it? As per here, you can see that this is an intraaxial tumor of right temporoparietal region. This is a morphology. You can see the normal parenchyma here. This is a cellular. You can make it draw a line distinguish, but still that you can see some cells are infiltrating here. Yes, these are the different ways. Okay, I tried to put in higher part of the interface. You can see there's some cells scattered infiltrating here, but you can still make out that they are one line you can draw. Yes. Okay, but they may not be usually called as circumscribed, but it's a high grade, but in interface is distinct here. So based on histology, we may not really call it a diffuse type, right? But it is having a cellular tumor, high grade morphology. So whenever you have any high grade tumor, you avoid using the word as circumscribed astrocytic glioma. As long as the tumor is lower grade, the diffuse and circumscribed comes. Many of these high grade tumors can be circumscribed on histology and even radiologically also. Okay, Chair, yes, you are asking something?
So I wanted to ask, the stroma on the right side, is this the necrotic? Yes, sir.
No, this is normal parenchyma, native parenchyma.
Okay.
Here,
yes.
We took the picture only to show that how you can see the tumor is suddenly stopping here. There are a few scattered cells minimally coming here, but it is not like. Whereas unlike the other cases, first 3 cases you saw, you could not make out the difference in normal parenchyma here.
Okay, sir.
Okay. So the same to highlight that how the tumor is same morphology across everywhere. This is GFAP. How will you interpret GFAP, Abhirami?
The GFAP is positive in few of the cells, scattered cells.
Here, and some areas it is showing positive here, and few of the cells, but predominantly areas are negative. So what you will call? Glial or no glial?
Still can be glial, sir.
Yeah, still can be glial, but because of an epithelial morphology, it has lost the GFAP expression.
Variable.
Okay? Variable, intraparenchymal. So at this point, if you do not get this area of positivity, probably it will be difficult for you to say it's truly a glial or not. You keep all options open with this. So what next? If you get GFAP negative, what next?
Because of epithelioid morphology, I would like to have an EMA.
EMA, yeah, you saw the pictures here in EMA. So
EMA
before you go to EMA, no, I'll advise you, we're not shown the panel. You can ask for other glial markers like OLIC2, because your morphological impression is a glial has a very high end on the priority. You should do for ascended protein, OLIC2 if you have it. If you don't have it, fine, we can still go at it, but you should always do the panel of glial marker to prove that it's a glial tumor.
Yes,
you had. So EMA, you said, how will you interpret EMA?
so here it looks like a few cells are membranous staining, showing membranous.
Yeah, so what does it mean?
Positive.
Positive. Will it tell us anything more? It reinforces your finding of epithelioid. Anywhere across any body, whenever you have an epithelioid phenotype, you get EMA positivity. It does not tell you anything. Don't jump into conclusion of an ependymoma EMA positivity. EMA membranous positivity is not a feature of ependymoma. Membranous positivity only tells you about epithelioid. Okay, it is here. So like other cases, we did IDH1, which is negative here. Okay, I is missing, sorry for that. P53 is at least more than 10% of cells strong positive. ATRX is retained because somebody told us an abdominal morphology INA1 is done retained. So what do you want to call here? Anything which you want to suggest?
So BRAF.
BRAF is there, but at this point, you, because of intraparenchymal, right within the brain parenchyma, you are thinking of epithelioid, a high-grade glial tumor of epithelioid morphology. So, what are the differentials?
Glioblastoma.
Epithelioid glioblastoma, or sometimes a high-grade pleomorphic xanthoastrocytoma, which can have epithelioid morphology. But usually, an high-grade pleomorphic xanthoastrocytoma can have low-grade areas, and uniformly it will not be across everywhere same morphology. They will have some heterogeneity. Here you saw the tumor is uniform in appearance across entire tumor, so your possibility of epithelioid glioblastoma is very high priority. Irrespective of it, epithelioid glioblastoma predominant ones, they are BRAF V600 mutant, so you can ask for BRAF, which is also there for immunohistochemistry. Okay. So this is another immunohistochemistry for a mutant specific BRAF. Okay, you demonstrated cytoplasmic positivity. You can see here.
Yes.
I put this picture to show that how the normal tissue is negative, only the tumor cells are positive, and the endothelial cell is negative. See, so at least like using this marker, you are picking up a BRAF V600 mutation, and when you combine with your morphology, it will become like epithelioid glioblastoma is what type of tumor? IDH wild type. That is glioblastoma. So what's your diagnosis? It's a glioblastoma because it's an IDH wild type BRAF V600 mutant. You show. You can put it in the bracket as subtype epithelioid morphology BRAF V600 mutant. CNS WHO grade 4. So you here you saw another IHC marker which can be used as a molecular marker. That is BRAF V600. Okay.
Yes, sir.
Yeah, this 14. So this is the ends about the spectrum of the first 5 cases of diffuse glioma. Abhishek, could you unmute yourself?
Yes, sir, successfully. Can you hear me?
Yeah, we could hear you. You want to sum it up and any information, a broad spectrum we told, just to re-emphasize from our clinical perspective to the pathology residents like?
I think the history and the clinical features in each case, if we see, always gave some clue as to which direction we were heading in. So the nuances, if we discussed the pathology in great detail, but if we look at in each case, the clinical history gave some hint as to which direction in which we were going, low grade or high grade, as in a relatively chronic disease process or a very acute disease process. And I think this little bit of history and cognizance of the imaging is of some help. What do you feel, sir?
Yeah, so what you said, like, what I wanted to know that from you is to tell them how important for you in the clinics to know for IDH mutant or not. Is it really important or not? Or for only for the classification purpose we are classifying?
It is important from 2 points of view. One thing is you are able to you are able to prognosticate the patient. It makes a huge difference for the patient to know that there is a at the 5-year survival of a glioblastoma is still around 70%. Sorry, 10%. The 5-year survival of even a high grade IDH mutant tumor grade 3 can reach 70%. So it is of great benefit to the patient when you are able to counsel and prognosticate them on the basis of this, and therefore definitely IDH has a lot of clinical importance. Also, the first generation of IDH inhibitors have started coming into clinical practice. In fact, a month ago, the first paper came out. The results are small but tangible, but we expect they will get better and better, and they will have very important implications for therapy maybe in a few years. So both from prognostic and predictive, it is going to assume even greater and greater importance as time goes. So I would say IDH is very, very important.
Okay, thank you, Abhishek. You understood not only why are we classifying, because it has got relevance in the clinics for prognosis, and also to explain whether we can plan for second salvage, long-term plan treatments, or you should go for all out. So there are many aspects. So not only you're classifying the tumor based on WHO classification, also give some information to your clinical colleagues who treat the patient, some kind of prognostic information to that. Okay. Pooja, can we go to the next team for the next subset of cases?
Yes, sir. We have answered all the questions which are all asked in the chat.
Okay.
Yes.
So thank you, the team one, like Shreya, Anita, and Abhinami, but you have to be there around. Probably might get some surprise questions also.
Yes.
Can we go? Pooja, can you ask the next person to take this case number 6?
Yes, sir. Hanan, can you please take the case?
We have a 14-year-old male. MRI shows a right frontoparietal space occupying lesion, solid cystic mass. This is a cellular smear with showing the congested and dilated blood vessels.
So it's not a smear, it's a slide. Actually, these you can use, like you can say that these are representative photomicrographs showing a cellular tumor. Okay.
Yes, sir.
This picture, and this area you can see here, these are all. What is this one?
In the right upper corner is necrosis.
Yeah, so cellular tumor with necrosis and quite vascular tumor. You can see a lot of blood-filled vascular spaces. So on higher power, how if you want to describe it?
This is a hypercellular smear with the monomorphic cells and the blood vessels. Around the blood vessels, there is a meshwork of fibrillary cytoplasm forming the pseudo-rosettes.
Okay, so you are saying tumor, which is a very monomorphic kind of, similar kind of looking irregular oval-shaped cells interspersed with some kind of acellular zones around vessels. What is this vessel? Is this a normal vessel? This one?
Yes, sir. Single layer of endothelial.
Okay, but anything about morphology of endothelial cells? They're plump or indolent cells? So plump cells, plump endothelial cells, not really qualifying as a microvascular proliferation, but definitely not like typical as a naive or innocent or innocuous blood vessel, right?
Yes, sir.
So at this point, what's your impression?
Highly cellular tumor with monomorphic cells and forming and the blood vessel and there's a formation
branching thin walled blood vessels at places that plump endothelial cells. Yeah, then is there anything in this area, in this portion of the slide? I'm marking it. Is there anything which you want to highlight in this? Anybody else in the team? Is this
clear cell
Sir, few
changes?
cells are showing clear cell changes.
Yeah. So what is highlighting is there are cells which are perinuclear halo around it. You can use the word clear cell, or definitely haloing is there. Okay. So why I want to stress is sometimes when you're not processing is not good, you may not appreciate the clearing. Okay. And section when it's thick, you may not appreciate. Okay. But you need to look that there are some areas when better preserved area, you have this clear cell. Okay.
Yes,
So
sir.
what is your summary?
So
14-year-old supratentorial located tumor. The matrix is very cellular tumor. Matrix is fibrillary. So what is your summary? Is it a low-grade tumor, high-grade tumor? First and foremost, is it a tumor or not?
yes, sir, it's a tumor.
Okay. I mean,
Cellular.
tumor means what type of tumor? You had glial tumor, you have embryonal tumor, you have glioneuronal tumors, you have what type of tumor is it?
So glioneuronal tumor.
Glial tumor. Why neuronal? It's a glial tumor. So if you're a glial tumor, higher grade or lower grade?
Mostly high grade tumor.
Why mostly?
So the cellular.
So it has to be. If there is any component which is high grade, you have to assign that as an high grade tumor. It's not mostly. Necrosis is there, cellular plaquing is there. Probably we didn't look hard for the mitosis, but definitely. So you're looking for a supratentorial located tumor which has got a high grade tumor. What does this morphology? You highlighted some areas like this. Like this one. These areas is what?
So fibrillary processes of tumor.
Around the vessel. What does it tell you?
So pseudo-rosette formation.
It's a like perivascular ependymal like rosettes. Okay. So with this, your differential would be, first differential would be?
Supratentorial ependymoma.
Ependymoma as well. Supratentorial ependymoma, what are the two groups of supratentorial ependymoma?
So we have ZFTA fusion and YAP1 fusion.
YAP1 fusion. Is there any IHC surrogates for anything?
Yes, sir. L1 CAM. It is positive in ZFTA.
So what is this one marker?
Sir, L1 CM.
So is it positive or negative?
Positive.
Huh?
So positive.
So you can see that vessels are negative and cells are all membranous. This is a cell adhesion marker. You will get membrane-like markers. Okay. Histologically features, you can have clear cell morphology as a surrogate for your ZFT. So how will you write the report? So what is the interpretation finally?
Supratentorial ependymoma, ZFTA fusion positive. Then we will grade accordingly.
So what grade? You saw that no necrosis and everything. What are the grades of ependymoma available?
Grade 3.
Grade 3. That's fine. So here I just want one caveat here you need to understand. You can see the L1 CAM positivity. There are other tumors you can get focal positivity for L1 CAM. But no other tumor will ever have so strong diffuse homogeneous positivity. So almost diffuse homogeneous positivity L1 CAM is a surrogate for an ependymal tumor and a supratentorial ependymoma. Understood? So whenever you are interpreting L1 CAM, it has to be diffuse positive and throughout the tumor. And L1 CAM positivity is a surrogate for ZFTA fusion. Okay. So here it is positive. So you have ZFT. So in case of ependymoma, IHC markers is important is L1 CAM, which is used as a surrogate for ZFTA fusion. Okay. This is the current classification, which is based on the ependymal tumors. The grading is still by histological features. There are no molecular markers for the grading. You have to do by the grading, but based on the histological features. Okay. And each one has got a subset of the supratentorial is one broader group, posterior fossa ependymoma, and spinal ependymoma. These are the three birds. So here it is supratentorial ependymoma, L1 CAM positive. You can write supratentorial ependymoma, ZFTA fusion positive, CNS WHO grade 2. Okay, 3, sorry. Is that fine?
Yes, sir.
So these, if you want to see the markers, you can use like this. So supratentorial ependymoma, you can use L1 CAM. If you have P65, you can use P65 as well. P65 and L1 CAM positivity is for the ZFTA fusion. If you have L1 CAM and P65 negative, that indirectly tells you it's an AP fusion positive. There is no positive marker for AP fusion group, but negativity for L1 CAM and P65 should tell you as an AP. So using an immunohistochemistry panel of L1 CAM and P65, you can decipher these molecular groups of supratentorial ependymoma. Got it? Yes?
Yes, sir.
So similarly for posterior fossa ependymoma, there are two groups. Posterior fossa ependymoma group A, posterior fossa ependymoma group B. You can use the markers of S3K27 ME3, the one marker which you use for the diffuse midline glioma, and EGEP. When you get EGEP positivity and S3K ME3 loss, it's become PFA. And if it is negative, it is PFB. Okay, spinal ependymomas, not much of immunohistochemistry markers are available for you. Yeah, there are markers of immunohistochemistry for NMIC, MICN. If you have it, if you do positivity, you need to use as a screening marker to identify this group. Otherwise, there is no IHC marker for molecular marker for spinal ependymoma. We'll see another case of posterior ependymoma. Can this other person can see? Can tell this case?
This is a 5-year girl child presenting with vomiting for 1 episode every morning and headache. MRI shows well-defined mass lesion in fourth ventricle, measuring 3.3 into 2.8 into 4.7, compressing the brainstem, displacing cerebellar vermis with focal extension up to foramen of Magentic.
So it's a posterior fossa mass in a 5-year-old child. Okay.
Yes,
so what is it? Can you describe this?
Sir, this section shows the monomorphic cells of variable density.
So you see that first you say that there is a tumor here. We can see very well here. What is this one? What is happening? What is this one here?
Ependymal lining.
There is an ependymal lining. If you can read the history, probably fourth ventricular mass is said. So that will be fourth ventricular lining problem.
Yes,
and you can
yes.
see a tumor which is very well
Demarcated.
demarcated tumor. And tumor is more or less uniformly similar.
Monomorphic
Right?
population.
Monomorphic population.
Now you can tell me what it is.
What's that?
You describe this one. The same area which has got an higher power.
Sir,
You can see the same features, cellular crowding, similar cells,
crowding, yes,
interspersed with the vascular channels, okay? And interspersed with some areas of, what are these? Necrosis.
necrosis.
And what is this foci? Here,
Which one, sir?
this one I marked it here. You can see with rays.
Sir, blood vessels. Sir.
Blood vessels, thickened wall.
Thickened
so
wall.
this will amount to microvascular proliferation. I was talking to you as an adventitial proliferation. This is an adventitial proliferation encompassing the microvascular proliferation.
Microvascular proliferation.
Okay.
Yes, sir.
So this is a higher power view. You saw that. What is this machine? You should describe nicely this one.
This is the this photograph showing there is formation of true rosette, and
This one. How will you describe this? Yeah. What is this? Describe this one. Whatever I'm encircling, describe this.
sir, actually these are the true ependymal rosette.
Why the true ependymal rosettes?
Because the lumen is free.
So you have a luminal outline here and
Yes.
cell-free and nuclear-free zones around the nucleus pushed at the page. This is a canalicular rosettes, likely to be true ependymal rosettes. Okay. Sometimes it is very difficult about you have any flux nerve intestinal rosettes. You have difficult. Sometimes lumen space will be, so you have to use the word canalicular. When you have a very well-defined internal luminal membrane, that is what canalicular. There's a true. In this case, ependymal, true ependymal canalicular rosettes.
Canalicular.
So what is it? What's your interpretation?
Sir, this is a ependymal tumor of posterior fossa origin.
Yes, very good. Posterior fossa ependymoma. So what should be our IHC panel?
Sir, H3K27 ME.
ME3, very good. So whenever you get an posterior fossa ependymoma, what are the markers you will do? S3K27 ME3, the second marker?
Sir, NMIC.
No, NMIC is
no,
what? Spinal.
Spinal, sorry. Yes.
What is this one?
Egypt.
Is that okay?
Okay.
So you have to remember two markers, EZIP and S3K27 ME3 for posterior fossa ependymoma. So what you, if you want to call something as posterior fossa A, what should you get?
Egypt positive and the loss of H3K27 ME3.
Okay. So now what should be your panel now?
Sir, Egypt.
Interpret this. First, you need to prove that it's an ependymal tumor. Okay. Which are morphologically what you are having.
Olic2 negative.
Negative. Mostly few cells around cells are there. Mostly it is negative. So ependymomas are always Olic2 negative. Okay. Whenever you get Olic2 strong positivity or more than 20-30% cells positive, stay away from the diagnosis of ependymoma. Okay, there are a lot of ependymoma mimickers. So to call something as ependymoma, you can use OLIC2 as a good marker to differentiate from its ependymal mimickers. So this is BCOR. BCOR is one of the young child. BCOR, you read
Sir?
about BCOR internal yeah.
Sir, that OLIC2 can be positive in around the rosette.
No, normally you should get very few. If it normally it is negative, even if positive, there are very few cells will be positive or weak positive. It's not rosette around. The OLIC2 is not a marker. It should be negative in ependymas. That is fundamental. So BCOR we are done to mimickers of BCOR, altered BCOR, IHC is negative, but it is not a very specific. This is BCOR, IHC can be used as a surrogate for BCOR internal tandem duplication, but not specific. If it is positive, it tells you that yes, there might be underlying internal tandem duplication or activation of the BCOR gene. Okay. This is S3KB3. How will you interpret this?
Loss of expression. Mostly.
So what does it tell us?
Posterior ependymal tumor of posterior fossa origin.
PFA. No, it's not
PFA.
specific for origin. Let me tell you one thing. S3K-ME3 is a marker. You used it in thalamic midline glioma also same. So only when you make the diagnosis of ependymoma, that is in posterior fossa, then only you need to apply S3K27ME3. You should not use this as a marker as a diagnosis for posterior fossa ependymoma. First, you confirm this is an ependymoma by using OLIC2 and mimicker you ruled out BCOR altered, OLIC2 negative, so you came here. In a diffuse midline glioma, OLIC2 is always positive. So OLIC2 negativity tells you that it is not a diffuse glioma, you are looking at an ependymal tumor, okay? GFAP we are not shown, GFAP is positive. So here you confirm that it's an ependymal tumor with the posterior fossa. Now you need to classify this as a PFA type or PFB type. When you want to come with the PFA or PFB type, what are the markers you use for S3K27ME3 and EGEP? So you did S3K-ME3, which is loss, tells you that likely to be PFA, that is type group A type, and this is EGEP. It's a nuclear marker, which is overexpression. Both EGEP is positive and S3K-ME3 is loss. So what's your diagnosis?
Sir, integrated diagnosis will be ependymal tumor, posterior fossa group A. Histological group will be ependymal tumor. Grade will be 3. And molecular.
Yeah, molecular will be? What are the groups of molecular in posterior fossa ependymoma?
H3K27ME3.
That loss is called as, you have two groups in posterior fossa, that group A, group B.
Group B.
You don't have to specify as an S3K-ME3 altered, unlike the diffuse glioma. The loss here you are supposed to say it is group A or group B. So you have markers like EGEP and S3K-ME3 to distinguish or to assign different molecular groups of posterior fossa ependymoma. Understood?
Okay.
Yeah?
Yes, sir.
So what are the molecular, somebody can sum it up, what are the immunohistochemical markers for for molecular grouping of ependymoma? Nakib, you only tell.
Sir, first OLIC2 we can do.
So OLIC2 is a marker negativity for a diagnosis of ependymoma. I'm asking immunohistochemistry markers for molecular grouping of ependymoma. Once you came to the diagnosis of ependymoma, you required only 3 markers.
L1 chem.
Yes.
L1
P65. I'm not said P65.
Okay.
EGEP, S3K-ME3.
S3K27ME3. Yes.
Okay. So once you made a diagnosis of ependymoma based on what are markers, first, depending on the location, if you have separate location, you do L1 cam. Okay, to say it is ZFTA fusion positive or YAP fusion positive. Positivity tells us ZFTA fusion positive, negative tells us YAP fusion positive. Posterior fossa ependymoma, you have S3K-ME3 loss and EGEP positive, you have group A type, and you don't have EGEP negative and no loss of ME3, it is group B type. Okay, that tells you about the immunohistochemistry markers for ependymomas.
Okay.
Is it clear?
Yes, sir.
Pooja, any questions?
No, sir.
Anybody chat, any questions? Abhishek, you want to say anything about the ependymomas before you go into the last subset of the cases?
No, sir. I think we're fine. Or
Yeah.
just one thing, again, a little bit of input which comes from the clinical history. Like, sir, we keep discussing 5 years of age. It's a reasonably decent partitioning between PFA and PFB also a lot of the time.
Yeah. So what he wanted to say that most of the time, less than 5 years or 6 years, they turn out to be PFA type only. But application of these IHC will be more useful in this the 5 to 10-year-old, where you can get PFA type also, A type also, or B type also. You can use these markers. Okay. Pooja, can we go to the next case?
Yes, sir.
Yeah. Next 2 cases. Very straightforward cases. Who is taking these cases?
Kumudini is taking, sir.
Kumudini, can you do it fast?
Yes, sir. So case number 8 is 1 year, 9 months old girl child. Vomiting since 4 months, 89 episodes a day, and weight loss of 1.2 kg. Headache since 2 months associated with plucking of hair and regression of milestones with 1 episode of GTCS.
So basically, it's an infantile age group child, and you had symptoms of raised intracranial tension, and for that, okay. So MRI showed a large mass in the posterior fossa, okay, predominantly solid. Histology is this. You describe this slide.
Sir, in this image, one part is showing a normal choroid lining.
Choroid plexus, fronts, very
Choroid
good.
plexus,
So
front,
tells
sir,
about the fourth ventricular side.
Yes, sir.
Yeah, the
And
other part.
the other part, sir, shows a tumor with densely packed tumor cells.
Densely packed tumor cells. Yeah.
Of variable sizes.
Of variable
Sizes, sir.
sizes, yeah.
Sir,
You
in
can
this slide, you
see.
can see the
Yeah,
tumor
you
cells
can
are
describe
showing.
here.
Yes, sir. The tumor cells are showing marked pleomorphism. Sir, few of the cells are have round nuclei and indistinct eosinophilic cytoplasm, whereas few of the cells have round nuclei with the clear cell changes. And
Yeah.
so few.
So more or less
there are-
nucleus, if you see carefully, more or less the nuclei are similar type. Some showing conspicuous nucleoli, not a macronucleoli. There are showing clearing, and few cells show eosinophilic cytoplasm. In a young baby, 3-year-old, posterior fossa, when you have morphology like this, okay, places clearing, very packed. What should your differential are? So what is your thought process here? At this point of time, what is your differential?
Sir, it can be an embryonal tumor.
Very good. Embryonal tumor, and in an embryonal tumor in a posterior fossa infantile age group, what should be the IHC panel first you want to do?
Sir, we can go for INI 1.
So just a MIB1 to show it is a very high grade.
It's a
Okay.
highly proliferating tumor.
So confirms you that embryonal state. This is synaptophysin. How will you interpret synaptophysin here?
So the
So weakly positive.
weakly positive
Doesn't carry much evidence, but weakly positive you can say. This is cytokeratin.
So this is
Weakly
also,
positive. Some
weakly
cells has
positive.
got a weakly positive. What does it tells you direction? What is this like?
So there is a loss of expression of INI 1.
Okay.
Sir, INI
So
1.
what are these positive cells are?
So these are endothelial cells.
Native endothelial cells like here. It is retained. That means this IHC has worked well. And you can see a lot of these clear cells which you are seeing in this picture are negative, right? These cells are all negative. So there is loss of INA1 expression. What does it tells you?
The loss of INI1 expression is seen and it's an essential diagnostic criteria for ATRT.
So in an infantile age group, loss of IHC in embryonal morphology, when you have a divergent differentiation like A1, A3 positive a bit and synaptophysin positive here, you should always think of ATRT, atypical teratoid rhabdoid tumor. Very good. Okay. So this is the higher power picture of INA1. This is another IHC utility marker of INA1 protein, IHC, which loss of expression is a marker of loss of functional alteration of INA1 gene. You also have another protein which is BRG1. A small subset of ATRTs can show BRG1 loss also. So BRG1 and INA1 are a good immunohistochemistry marker for atypical teratoid rhabdoid tumors. Loss of expression of INA1 and BRG1 are the markers for atypical teratoid rhabdoid tumors. Okay. So you have few cases like they can get focal positive brachyury. You should not jump into conclusion. Brachyury is a nuclear marker for chordomas. Sometimes polydifferentiated chordoma can come INA1 loss or INA1 loss expression. So when you have INA1 loss, focal positive or few cells brachyury positivity should not be considered as polydifferentiated chordoma. Okay. So you can get ATRTs as few cells of brachyury. That is the reason this picture has been shown. When you want to interpret brachyury, brachyury should be through and through all cells. This is a marker of notochordal cells when it comes through and through all cells. So INA1 loss with no diffuse positivity of brachyury, it's a diagnostic feature of atypical teratoid rhabdoid tumor. Okay, when you say what is the grade for atypical teratoid rhabdoid tumor?
It is a grade 4 tumor. CNS WHO grade 4.
Grade 4, very good. So this is one of the specific subtype of embryonal tumor where you don't require any molecular features. If you have a panel of INA1 and BRG IHC panel, you can diagnose this subset of tumor. No high-end molecular techniques are required to identify these tumors. Understood? And any questions, Pooja? We can go to the 9th case.
Yes, sir, we can go. No questions.
Yeah, 9th case, please. Who is taking? Kumudini, you are only taking?
Yes, sir. So case number 9 is 10-month male child, complaint of ptosis of right eye for last 20 days. And the mass lesion involving suprasellar region with extension into interpeduncular prepontine cisterns and infiltrating right crus cerebri, right midbrain.
So there is a mass lesion suprasellar and going into the prepontine region. Say, okay, mass in a 10-month-old baby, less than a year child with multiple mets in brain and spine. Right? What is this morphology?
So the image shows a highly cellular tumor, densely packed tumor cells with few hypocellular areas.
Where are the hypocellular areas? These are blood vessels. These are blood vessels.
But I thought the hypocellular areas are the neuropil-like material.
But where is it? This is at least in this power, you can say that, okay, the patchy of hypocell, which is predominantly comprised of the blood vessels. Okay, now you see how will you describe this area, the cellular area.
So the cellular areas show tumor cells which are small in size.
What are these dark dots? What are these dark dots?
Sir, these are mitotic figures.
These are apoptotic bodies.
Apoptotic bodies.
So you have a packed cellular tumor. Cells are maybe you can't say small, you can say intermediate, small to intermediate, more or less of similar size all throughout, and has got a very high apoptotic index. Okay, it tells you very rapidly, highly proliferating tumor. So what is your impression? You can see this. The tumor cells have some kind of arrangement around the blood vessels.
Around the blood vessels.
Radially oriented, but no very pre-cellular cell-free zones or acellular fibrillary zones. It's all packed and going up to that apoptotically. What's your differential here? If you want to club this tumor or assign a family of tumor, what tumor you will call?
Sir, because it is in a because of the age group and because of the apoptotic bodies and plus high mitotic index, sir, I would like to place it in embryonal tumor.
Very good. So again, this is again an embryonal tumor, which is very packed, very high mitotically active, as you said. So what should be your IHC panel? So you have few entities which you can pick it up as a specific entity based on IHC. What you described last case was you have INA1 and BRG. Would you like to do that first?
Sir, in this we can go for LIN28A.
Directly. First, do whatever standard person prove it is this thing. New1 is a neuronal. First, you need to do the INA1, which is commoner. INA1 is, how will you interpret INA1 here?
Sir, there is a retained expression of INA1.
Unlike the last tumor, it is retained here. Okay, this is BRG. What is it? BRG is also retained.
BRG retained expression.
So INA1 retained and BRG retained. What does it tell you?
Sir, it rules out ATRT.
Very good. So the commoner, a non-medulloblastum primary tumor, so the ATRT commoner in infantile age group, first you need to exclude that. So here with INA1 and BRG is retained, so ATRT is excluded. That brings you a picture about other spectrum of tumors. There, because of the perivascular pattern, you can keep one of the differential as poorly differentiated embryonal tumor multilayered rosettes. You can do the Lin28. But before that, you can do other markers for BCOR, as a BCOR altered tumors also in embryonal. You can see not very few cells, not a strong diffusion. So it is BCOR is also negative. So that brings your Lin28. What is Lin28? Here?
Sir, there is a diffuse cytoplasmic positivity.
So what does it tell us? So diffuse strong positivity of Lin28 is a surrogate marker for embryonal tumor with multilayered rosettes. Most of the time when it is positive, it corroborates with the C19 marker amplification. C19 microRNA complex. C stands for chromosome, 19 is numerical. Chromosome 19, you have microRNA complex amplification, which can be done by this. When you have like this, you can use a diagnosis as embryonal tumor multilayered rosettes. You can put it as NOS, CNS, WHO grade 4. If you have IHC of fish, these are the green dots which is implied here for C19 MC is amplified. You can put it as C19 amplified. You can make that as a ETMR CNS grade 4. However, this is a poorly differentiated tumor. So classic case will be like this, what we saw. This is the classic picture of embryonal tumor with multilayered rosettes. This based on this morphology, the terminology has come. You can see how here the cells are a little bit lesser cellular, the packed cells are in the foci. You can see here. See this rosettes here? These are multilayered rosettes. These are multilayered rosettes. You can see stacking multilayered rosettes. So this is the classic picture of ETMR. From this morphology, the terminology has been proven. Okay. So earlier these tumors also used to be called as ependymyoblastoma, and now there's renamed as embryonal tumor with multilayered rosettes. That is a poorly differentiated spectrum. This is a but both are similar spectrum and molecularly one group only. You can see the same higher picture of a multilayered rosettes. Okay, I did not give a classic case. I want to tell you that Lin28 is a marker. They can have an overlapping, you can have an heterogeneous MIB1, but Lin28 is the marker which you can use for the surrogate for C19MC. Okay, diagnosis is embryonal tumor multilayered rosettes, which is in the long arm of chromosome 19 amplified microRNA complex. I don't want to go into the literature about it. You can see that. So one of you can take up the last case, which is the test, how much you learned. So before you go for the test, maybe Abhishek, you want to say anything about further? I think fine. Pooja, any questions?
No, sir. No, sir.
Yeah. Pooja, any questions for the embryonal tumor?
No, sir.
So both these tumors of ETMR and ATRT are high-risk embryonal tumor. They're always clinically stratified as an high-risk group tumors. So use your IHC panel. It will help the clinical side, clinical colleagues to stratify these babies into high-risk protocol and treatment and prognosticating further. Now, if that is over, like maybe you can take the test, how much is there. So who is going to volunteer for this case? Maybe Kumudini, yeah, want to take it, take it.
So 2 years male child with complaint of fever, multiple episodes of vomiting, decreased appetite, along with a gradual drop in sensorium with seizure episodes. The lesion is in a right parieto-occipital region with a midline shift of 1.4 centimeter and mild hydrocephalus.
So this is the picture. So what is a 2-year-old baby in a right parieto-occipital region, supratentorial location? Yeah. What is it?
Sir, we can see a well-demarcated, highly cellular tumor.
Well-demarcated tumor. Yes.
The normal leptomeningeal lining.
It's not leptomeningeal. It's a native parenchyma only.
A native parenchyma and a well-demarcated tumor, densely packed tumor cells.
And the tumor cells, how it is arranged?
Sir, here we can see, yes, sir, the cells are monomorphic with round nuclei, and we can see proliferating capillaries in between, branching capillaries with few of them showing chicken wire morphology and few foci of microcalcification as well.
Yes, calcification. How do you say this? There are areas where
Sir, the tumor cells have round nuclei and the clear cell changes, they have perinuclear clearing.
Also, halo is there. Okay. But back 2-year-old baby. What is these areas? Necrosis. So cellular packed tumor, areas of necrosis. Anything different in this morphology in this slide? Same, unletting, better of perinuclear halo, right? But so what is your differential here? You saw here a 2-year-old baby, supratentorial mass, cellular tumor, necrosis, monomorphic, round cell at places so-called clear cell. What do you want to classify? This is you want to classify as glioma, do you want to classify as embryonal tumor, or what is it? What is the panel you want to do?
It is a oligodendroglioma-like morphology.
Oligo-like morphology, yeah. So what is the panel you want to do?
So we can go for olig 2.
Olig 2. This is, you want to see the synaptophysin you want to interpret?
So it is
very weak positivity, does not tell you anything. Any tumor in the brain tumor can have this kind of synaptophysin positive. So just because you get synaptophysin positive, you should not say that it is not a glial. Okay? So synaptophysin is a very poor marker in primary brain tumors. Don't interpret too much. Only thing, because it's a 2-year-old baby, if at all, if you want to think of it as an embryonal tumor like, I put it the marker like this. Synaptophysin is weak positive, but it does not tell you anything further. This is GFAP. How you want to evaluate?
So GFAP is coming out to be positive in the background. The fibrillary processes are positive for GFAP.
It's a very boxcar, cell car. Like, you can see this all cell membrane is nicely positive.
Yes.
There is no processes you are seeing. Okay. If GFAP is positive, what do you want to call?
Diffuse glioma.
Somebody said diffuse glioma. Did you see the first picture?
Yes.
You saw this now? He drew the line like this. So well demarcated tumor. Why do you want to call it diffuse glioma?
No.
So GFAP is positive. So what next? What is your differentials here?
Sir, it can be oligodendroglioma. Sir, it can be
Where did you read oligodendroglioma? Where did you read? In which class of tumors did you read?
Diffuse.
Adult type.
Adult.
Adult type diffuse glioma. You are missing out the history. The 2-year-old baby post supratentorial. Why do you want to think oligodendroglioma in a 2-year-old baby?
No, sir, it is not possible because of the age group. So we can think extraventricular neurocytoma or
extraventricular neurocytoma. That's a high-grade morphology. GFAP is such kind of positivity. So first here is you have to think here. Am I dealing with an embryonal tumor? Am I dealing with a glial tumor? Am I dealing with a glial neuronal or a neurocytic tumor? So that is why I showed you these markers. Synaptophysin is weakly positive. If you're thinking of a neurocytic tumor, synaptophysin should have been more stronger positive. Yes, they can be GFAP positive, but they'll be weak. What is here? It is synaptophysin weak positive, GFAP strong positive. So probably synaptophysin is a aberrant or kind of not specific positive. GFAP is stronger. Will you still be able to think of a differential of embryonal tumor? Two-year-old baby, I did INA 1 and 2 because whatever higher grade tumor, it will be retained. Okay, so it tells you when INA 1 and BRG retained, what does it tells you?
Sir, it excludes ATRT.
Very good, excludes ATRT. We still can't say whether glial or not. What is this?
Olig 2 is negative.
So what does it tells you?
the glial tumors.
GFAP positive, Olig 2 negative, what does it think? Well demarcated tumor, not a diffuse tumor. GFAP positive, Olig 2 in this present series of cases, did you see any case which is GFAP positive, Olig 2 negative or Olig 2 tumor? Did you see anything? Okay. So what next? Did you want to do IDH1 R1?
Ependymal tumor can be.
Very good. So when ependymomas can occur in children, infant, and this thing, GFAP positive, olive-2 negative. If at all you're thinking about glial tumor, ependymoma should be your first. You should never ask for IDH1 R132H with this kind of morphology, even though it is glial and morphology. So in a 2-year-old baby, that okay. So it is not required. So this is IDH anyway. We have did it. IDH is negative. So if you're thinking of ependymoma, what is this marker? One of this marker is positive or negative?
It is positive.
But what is the marker? Which marker is likely to be? Somebody told ependymoma. What is the marker you do for supratental ependymoma?
Sir,
L1 cam, what does it come for? Membranous?
Yes, sir.
Can this be an L1 cam?
Yes, can be.
How many people are saying this can be L1 cam?
L1 cam
Does
shows
anybody feel that it may not be L1 cam?
It is membranous positive, strong, diffuse positive. So can be an L1 cam.
Yeah, there is nothing. Somebody says that it cannot be. No way it cannot be L1. It can be L1 cam. So this is an L1 cam antibody, which is positive. Now, what's your diagnosis?
Ependymoma.
Very good. Supratental ependymoma. ZFTA fusion positive. CNS WHO grade 3. Okay. So there are other markers also has been done in this case. I did not show you. BCOR is negative. BCOR we have done negative, but olive-2 usually positive in BCOR positive cases. Okay. So and LIN20 is also is negative. So here this is none of these embryonal tumors will come GFAP so strong positive. So this is a case where infantile age group, sometimes you can get ependymoma supratentorial, also an ependymoma like, and radiologically can mimic like a primitive embryonal tumor. So you need to be very careful. No embryonal tumor will ever have LIN28, L1 cam so strongly positive. When you have diffuse strong positive L1 cam, you should think of first as ependymoma. Okay. With that, my cases are over. Pooja, if I'm ready to take up any questions.
Yes, sir. There is one question. How to diagnose CNS PNET by IHC? Now.
Anybody? So I will only take up the question.
Yes.
So there is nothing called CNS PNET.
Yes.
Okay. There is a primitive embryonal tumor is the term which is used nowadays. When you cannot classify any further, primitive embryonal tumor NOS. Whenever you get an embryonal tumor morphology, your first task is to prove that it's an embryonal tumor, and you rule out the specific types. What you did for an ATRT, what you did for ETMR, you do markers INA1, BRG1, you do marker for ETMR like LIN28, you do marker for BCOR internal tandem duplication, ITD, you do markers for CNS neuroblastoma, TTF1. You can do that. You exclude that possibility. If any of them comes possibility, you can specify that likely to be that specific type. When nothing is comes positive, you should use the word as CNS embryonal tumor NOS. Is that clear? Anybody who is there?
Yes.
Yes, sir.
Okay. The participants like the who are presented, you have any questions?
Kindly tell me about that BCOR repetition.
So let's not get into the BCOR internal tandem duplication. It's a very kind of a difficult area for you guys right now explain. This is a tumor, which is a subtype molecularly kind of defined tumor where you have a duplication in certain regions of the BCOR, which has to be picked up by molecular evaluation only. You can use BCOR IHC as a surrogate, but that is not a specific. So if you cannot classify, you can leave it as an embryonal tumor NOS, it's fine. It's treated the same way. But this BCOR altered tumor, you can have ETMR, you have ATRT, all are high risk embryonal tumors. If you identify them, they will classify as an high risk group. Just remember this is an embryonal tumor. Today we learned about the diffuse gliomas, which is the commonest tumor. Most of us we deal with that. In pediatric, the commonest tumors are primitive embryonal tumors, which medulloblastoma is common. I have excluded that. Other than medulloblastoma, you still remember ATRT. You need to exclude ATRT. Rest of the cases, even if you don't identify ETMR is fine or BCOR is fine. They're treated in the similar pattern. Only specific type you need to know. That's embryonal tumor. Ependymomas, why it is important for you guys? Because ependymomas, absolutely, there is no need to do any molecular right now. If you have an absolute immunohistochemical panel, you can delineate all the molecular groups of ependymomas. So that's why I included that. Is that fine?
Yes.
Yes, sir.
Yeah. Abhishek, you have any comment? I think fine. It's quite late, no? Take care. Thank you, all of you. I think my best wishes for all of you for your exam and in future. I don't believe in this exam system. You are all
Sorry, sir, I
pathologists.
was just, it just takes me some time to log on.
No problem. I think it's fine, Abhishek. All are fine. You want to have some comment?
I think, sir, like this case classically showed, I think things like age and all, we really need to pay due cognizance to. And apart from that, I think it demonstrates the overall difficulty of the whole process of identifying these tumors when they tend to jump morphological and radiological boundaries. That's all.
So he told us very clearly what he wanted to tell is the importance of the pathology and your immunohistochemical markers in cases where the tumors transgress the conventionals, like age group, where you say locations and all. So you need to have these appropriate markers and you should know what are the markers, when to use it. Okay, so today you learned about the adult diffuse markers. What you learned at the IDH and ATRS are absolutely important for the adult diffuse gliomas. Ependymoma tumors, yes, if you're dealing with supratentorial, if you don't have P65, at least L1 CAM, we should have as a molecular marker. Okay, but posterior fossa ependymoma, you need to have ESEP. If you don't have, it's fine. S3K-ME3 you should have. S3K-ME3 is important also to identify diffuse midline gliomas, which is also an aggressive subtype. Okay, and we also saw some of these morphology variants of an IDH wild type of tumors like glioblastoma, epithelial glioblastoma. Important to have BRAF mutant IHC panel, which will help you to identify molecular marker. Okay, so these are one of the commonly used IHC markers which can be used as a surrogate for the molecular. You don't have to subject for the molecular. At least I will expect these 6 students who are there, they will not forget the name of these markers and for the name of the diagnosis. Maybe Abhiram is the senior most. She's going for exam on, I think March, next year. All my best wishes, but I'll tell you, you should not be worried. In exam, nobody gives their CNS cases so difficult. They'll give a classic case only. So don't worry about the exam, but in future, when you practice, you should know what it is. Okay? Thank you, Pooja.
Thank you, sir.
Patiently moderating it. Thank you, all of you. All the best.
Thank you, sir, for
Thank
the
you, sir.
wonderful session. There is a lot of appreciation in the chat box also.
Thank you. Thanks.
Yes. Thank you so much.
Thank you, sir.
Good night.